Ng?
Yan, yung kay Kevin.
Ano yan?
May ginawa si Kevin eh.
Ah, yan yung dati pa. Yung ginawa ni ano yan? Ginawa ni... Ginawa ni Joff.
Okay. Lahat na tayong ganyan. Para alam natin na tayo yung nag-ayos.
Ay.
Arlene. Arlene. Hindi, paano siyang... Arlene, nandiyan ka pa?
Yes.
Paano sendan daw si Dr. Sutep ng ano, as panelist?
Pahingi ako ng email, sir.
Sige. Sabihin ko na sa'yo ngayon. Sutep,
Wait.
S-U... Ay, di. Type ko na lang sa
Wait.
Viber para copy-paste. Okay lang?
Ay, oh, sige, sir.
Priority itong Gmail.
Wait,
Tapos,
teka, boss.
dalawang papadala ko sa'yo. Para sure.
See? Wala na akong gagawin. Woohoo!
Hindi ka na daw magano?
Eh, pili ko lang. Udom, ano?
Hindi daw mag-opening eh. Pinyari. Hindi, basta sasabihin naman daw Kalen, kumakain lang siya. Parang biglang sumahog.
After ano?
Ay,
after
sorry.
you, sir.
Siyempre, nakalimutan mo na. Yan mo. Airdrop na lang.
Sir, saan?
Okay ako. Yan, sa Viber, pinadala ko na sa'yo. Yung Sutep Gmail.
Anong apelido niya? Udom Sotepachutu?
Hindi, Sutep.u. Yes, sir. Naku, sir, ubos. Lahat. Hanggang desktop. Dahil lahat ng mga nagsuschool ngayon. Pero sige, sir. 13-inch. Yung pinakota. Ay, 15. Pero walang video card din, sir. Ano ba maganda? Siyempre yung mga starting 15. Pero ang sinabi nila, pinakasulit daw talaga 6. Malaki na ito. Mas malaki pa dito. Pero yung video card niya talagang 1 star talaga.
Magkano yun?
165.
Yung pinakataas.
Sige, sabihin ko ano.
Kaya mo sa iyo eh.
50 pa lang yan, sir. Mas mabigat pa yan. Teka.
Ito laki eh.
Hindi, sige sir, hanapan kita ng magandang... Sir, hanapan na lang kita magandang 13. Na magandang 13.
215.
Ay, sir.
Hi, this did not come as a link. Can you resend it? Nako, hindi. Nako, hindi niya nakita.
Hindi siya marunong, sir. Tanggalin mo na lang, bigyan mo lang sa kanya, bigyan mo lang siya ng link. Nakakainis naman itong si ano.
Si Dr. Nandito na. Naririnig ka ni sir. Naka-speaker tayo.
Hello!
Ay, sir!
Wala. Hindi narinig ni
Hindi
sir.
siya marunong.
Narinig ko, tangina mo.
Sir, hindi niya alam yung link eh. Ilang beses na natin siya pinapadala ng link. Ang ilan na natin siya napadala ng link. Open. Allow panelist. Oh.
Send ba yung link sa step?
Si Arlene Matanto.
Ma'am Arlene.
Oy. Uy, pahingi naman ako ng full. Pahingi ako ng full name ni Dr.
Sige po, kukunin ko ma'am. Ma'am, pwedeng pa-accept
Full.
na po si Sir Charles tsaka si Sir Temio.
Ay.
Wala pa kasi
Ah.
akong host privilege eh. Sorry.
Hindi natin sila na ano. Nilagay mo ba sila as panelist?
Hindi po, wala po.
Yarn. Dapat as panelist sila. Wait.
Oo nga, at next time ma'am. Sorry.
Wait ah.
Ma'am, check. Full name ni Sutep.
Wait lang. Uy, anong full name ni Dr. Sutep?
Udom.
Udom
Teka. May ano ka naman, di ba? May internet. May ano ka? Naka-share screen tayo.
Udom Sawang Soup, di ba? Udom.
Udom.
Sawaing.
Ito na. Copy-paste ko na lang sa
Sawaing soup.
Viber para wala ka
Okay na
ano.
boss, ito na. Nakita ko na sa internet. Udom
Okay.
Sawang Soup.
Yan na.
Sawaing
Sinend ko
soup.
pa rin sa'yo.
Tama. Okay.
Yes,
Okay,
Dr.
pause.
Achalasia.
Nandiyan na si Joel. Hi, Joel.
Hala, asan na? Asan na yung ano ni Dr. Sutep? OMG.
Nandiyan yung email sa
Sutep.u.
Viber.
Sutep.u.
Alex.
Okay, wait. Sutep.
Teka. Before anything else, Arlene, nakikita mo ba yung kay Sutep na email?
Yes, boss.
Okay, sige. Okay na yan ha?
Sutep.u@gmail, no?
Okay.
Ano yung pinarik tsaka pinarik?
Sa kanya rin. Pero padala mo na pareho, mamaya. Hindi na naman sabihin. Natin si Dr. Rinig ka sa kwarto.
Pinarik. Hindi niya alam. Hindi, yung si ano.
Sa pangalan mo, Timber.
Hindi niya alam yung link. Diba? Baka di niya alam kung alin din yung link.
Hi, sir. Link. Gusto mo ipo ko si yung pala pagmumuram po sa kanya.
Mark.
Nako-host mo na ba ako, Arlene?
Yes, boss.
Okay,
Ano ni Tem yung...
Okay ka lang, Joel? Okay ka lang?
Ay,
Alex, nakita ko lang parang may mga konting typos dun sa pinadala sa akin ni Johan na
Charlie.
Wala ka.
Pengi po ako ng ano ni Charlie. Pengi ako
Doon,
ng email ni
na-mute
Charlie. Pengi
Kaya
ako email ni Charlie.
parang overview dun sa outline natin. Kasi parang di ba may timeline ka ng 2 p.m., 2:10, gano'n. Tapos yung discussion is 5 p.m. na kalagay. Hindi ko alam kung yun ang na-publish or naka-publish ba ito sa ano.
Yun ang hindi ko alam. Sige, check ko. Ayun, nasa program daw. May discussion tayo separately, 5 p.m. Arlene.
Ayan.
Yes.
I share the screen. Can you share it?
Usually ang discussion sa dulo na eh.
panelists, 5 p.m.
Kasi lecture muna lahat. Tama ba, Arlene?
Yes. Yes, sir. Yes, sir. Yes, sir.
Galing.
Charlie name
Ah,
and
okay.
Charlie.
Yung panelist, Arlene, pag clinic niya, dire-diretso na, nawala na silang password. Ay, sir. Nako, pag hindi pa rin niya makita to. Galing.
Ayan na.
Baka naman read me pa rin to sa lumalabas sa kanya. Baka naman yung cellphone niya, yung gano'n lang. Yung lumang Panasonic na maliit lang. 90%. Ano 90%? SSD? 90%? Ah. Charlie. Email ni Charlie, please. Okay, malapit na pala tayo.
Oo, malapit na tayo.
Question.
Pwede pa tayo
Question.
Yes po, sir.
Ako ba magpa-flash nung slides nung intro? Pati yung sa intro ng speakers?
Kaya na ng host yun. Host na lang.
Kayo
Hindi
na.
ka na toxic. Ano
Kayo.
lang, basta ikaw lang magsasabi na for our next speaker or gano'n.
Okay.
So, ano,
Sasabayan na lang namin kayo, sir.
Alright.
okay na yung YouTube natin, no? Na-set na.
Yes.
Ito na.
I-play ko na lang. "20 minutes, guys."
Joel, yung mga ano pala natin, yung mga webinar, lahat na sa YouTube na. Except for the first. Kasi ibang meeting platform yung ginamit natin. Okay. Anyway.
Naman ni Sir Charles, nakalimutan ba?
Naririnig ka.
Sila.
Ewan.
Akala ba ni sir, siya yung sinabihan ko? Akala ba rin Dr. Benafe, siya yung sinabihan ko?
Wala. Siyempre, kaibigan niyo yun. Kung sabihin narinig. Ikaw talaga. Susunod na natin sa akin. Ang galing na lang.
Gwapo naman ni Charlie.
Dito. Kailangan yung mic ng laptop. Pwede natin gawin.
Naririnig ako? Hello?
Hoy, Temyong, galingan mo.
Hindi naman, ma'am.
Papasok na ba si Dr. Allenbert?
Wala pa, di natin siya nilagay as ano, sir. Basta lahat lang ng pwedeng pumasok ngayon sa practice mode ay mga panelists lang. Hindi tayo makakatanggap ng attendees kung hindi tayo nag-broadcast. So, pero tayong tumanggap in 10 minutes.
Hello?
In 10 minutes, pwede tayong tumanggap.
Okay.
Times, humihina yung signal mo. Nakikita ko na bumababa yung bars mo.
Hi. Hello?
Tsaka naglalag
Signal,
ka. Oo. Baka kailangan mong patayin any of your gadgets.
Yung mga
Ayan,
other
humihina.
Oo,
Narinig sa.
Kevin?
We're going online if you want to test.
Yes. Tawagan ko kaya si Dr. ano.
Sir Paras.
Tawagan ko na.
Actually,
Kasi
si Roy Morgan.
Sir na?
Ako na.
1:50. Mag-broadcast na tayo para start na
Ilang boss ba kasama dito sa event na to? Arlene? Hiningan tayo ng attendance.
Oo,
naman
talaga?
Ay, direct message.
Ang nakikita ko lang sa attendance, sir, puro Medtronic.
Hindi, si Kanan na lang.
Jason Te. Andito, sir. Si Jason Te. Naka-register si Jason Te.
Hi, sir. Sir, webinar natin.
My gosh. Ang dami nating attendees. 227.
Bakit ayaw?
Tems, yung poem mo ba may full duplication?
Nope.
Purely poem.
Purely
Purely poem. Okay. Kasi baka tanongin tayo dun sa may full duplication.
So, nilagay ko lang sa guidelines, ma'am, na yun yung recommendation dahil sa post-myotomy girl.
Ano pag-uusapan niyo dyan?
Okay. Ikaw, sir, ikaw.
Si Joel pa lang lumalabas dito sa ako nasa studio. Hindi, mukha mo yung unang lumalabas dito sa YouTube natin. Ayusin ko pa to.
Record in this computer.
Okay.
Record na lang kaya ako sa cloud. Pero bakit pag nag-record ako sa cloud, umagaw sa bandwidth no, sir?
Yep. Huwag ka na magana.
Takot ako kasi baka
Pero okay na yung YouTube. Okay na.
Ma'am Arlene.
Yo.
Ma'am, favor naman, si Dr. Roselio, pwede pong pa-inform na
Ay.
open up for
Oo.
body.
Sige, titext ko na.
Siya na lang po yung hindi pa na-inform. Thank you, ma'am.
Titext ko na.
Dapat pala to. Tanggalin ko yung ano. Arlene, diyan ka pa?
Yup.
So yung tinatanong ni Jason Te, yung Sri Lankan, tapos si Dr. Allen, i-track down daw lahat ng foreign.
May Indian.
Pag ano ba, pwede ko makita yun? For me? No.
Okay po, sir.
Sa website ko.
Teka, sir.
Okay.
Hindi ko kayang mag-multitask. Okay
Sorry.
po, sir. Padala po ako later ng CSV file. Electronic.
Tatawagan ko ba si
227 na.
Safaris? Parang hindi pa siya nagre-reply na thank you. Pero link lang tingin. Hirap talaga eh.
Bahala ka, sir.
Oh, uy, tulong na lang yan.
Oh, JB Lingad. Meron na tayo from JB Lingad.
Sino?
Ay, 1 minute. Broadcast na tayo in 1 minute.
Oo.
Okay, ma'am.
I
Sir.
encountered difficulty joining the conference. Are we online?
Sino yan?
Si Dr. Allenberg. 1 minute po.
Kasi hindi pa tayo naka-broadcast, sir.
So nga, pinost ko na rin doon in 10 minutes. 1 minute broadcast. O yan, nag-thanks na si Baig. Nandiyan na siya?
Ay, salamat.
Ay, naka-record to sa YouTube. Yari ka.
Hindi pa naka-record. Dahil hindi pa ako naka-broadcast.
Makikilala ka sa ibang bansa.
Hindi pa naka-record. Yeah.
Antayin mo daw mag-sa tayo doon. Tagalog naman yung pagkakasabi mo sa inyo.
Meron po tayo.
Okay.
Okay na to? Hindi na wala.
Okay. Can we broadcast na para tumanggap na tayo ng ano? Are we ready?
Okay. Okay na. Ano ka nga ulit? Cherry.
Ready na, everyone?
Mag-mic ka, Cherry. Mag-mic ka.
Mali pa rin yung link.
Ay, hindi pa kayo
Mali.
nakapasa.
Mali pa din.
Broadcasting na tayo, di ba?
Hindi pa, sir. Sabihan niyo ako kung magbo-broadcast na.
Broadcast mo na. 51 na eh.
Back.
What time? 10 minutes from now.
Ano ka?
Yes, sir. Panelists can enter. Panelist si Dr. ano, di ba? Sarfaras?
Sarfaras. Yes.
Can
Nawala yung taga-Sulu. Anong pangalan? Wad? Hindi.
Mawala pa. Mamaya, dami ko ng message masabi sa kanya, mawala pa tong link niya. Charlie, Sulu, si Dr. Wood.
Basta meron, hindi ko na siya makita. I'll be late. Doctor, I'll adjust. Okay po, sir.
Ano?
Nakatapos lang daw ni Dr. Roselio, habol si Dr. Roselio.
Hindi yata kasi ito. Arlene, ano ba to? Nakakapasok ka just to enter the ID? Ay, hindi
Ano,
pa
boss?
naka-broadcast ka na? Ay, teka,
Hindi pa. Mag-broadcast na ba ako? Pag nag-broadcast na tayo, yung mga glitches natin.
Hindi, sina Cherry kasi gusto makita eh.
Okay.
Yung may computer panel kasi sila sa likod eh. Kailangan mag-test run na rin nila. Kasi
So,
dun
okay.
yung-
Na-broadcast na ako? Everyone ready?
Okay lang.
Okay. Good luck, guys. Here we go.
Sige. Iba-broadcast na.
Broadcasting na tayo, ah.
Okay na?
Yep.
Sino nagtaas ng kamay?
Si RJ. Ang aga-aga.
Question lang.
May question na kagad.
Nakapasok pala
Harley?
question na.
Tawang-tawa.
Di ba kasi sabi na present? Present siya. Talaga. Sa broadcast. Sabihin ko broadcasting na. Broadcasting na.
Shucks, yung panelists, wala pa. Tayo-tayo pa lang.
Kaninong contact number ba yan? Chamber.
Johan!
Ano
Yung,
account mo?
yung mga kausap mo na Frenchies.
Arlene, pwede mo ba
Boss.
Sabi
invite
nila
si
ma'am,
Cherry?
magla-login sila ng mga 2:10 PM.
2:10. Ah, wow. So
Kasi
precise.
tinanong nila specifically kung anong oras yung kay Dr. Pereta. So sinabi ko mga 2:50. So start na yung tatlong speakers pero pangatlo siya. So sabi nila, okay, then we will log in around 2:10.
Okay.
So expect na lang natin.
Okay, sige. Antayin na lang natin.
Unless na gusto nyo doon na lang yung laptop ni sir. May laptop si sir na pala.
Yung link na lang ni Dr. Buenafe, yung igagamitin natin dun sa ano? Paano ba?
Hindi ko nga alam.
Anong laptop yung gamit nila, Ma'am Cherry,
Kasi
sa loob?
gamitin yung mic. Kaso wala tayong video card, audio card.
Hindi na kailangan na yun. Kailangan ilink ko lang yun.
Kung ililink na doon na lang si sir.
Hindi ko nasasakit sila pati yung alin, yung audio table.
Okay na. Sino pumasok? Hi, sir.
Okay, kasi makikita kasi si Chen.
Yan na si Dr. Sutep. Dr. Sutep is already here. Good afternoon, sir.
Hello, thank you. I'm excited to show you here.
Sawadee ka.
Sawadee ka, sabadi may ka. Sawadee ka.
Hello!
Hey, bro! Let me show you.
I like your hair.
Boss. How's look? Hey, look at you, huh?
Hey bro, good idea. Huh?
Of course. Let me have a look first.
Hey, Sutap, can we do a combined meeting? Your resident and fellows and UMIST.
Sure, my fellows.
And then
yes.
we share cases. Like if you have a good case, we'll discuss about it together. And then if you have a good case, we discuss it together with you.
See, look at me. How can I manage? Okay, let me check. I'm in my office together with my colleague, my fellow.
Eileen, all of our
Sir.
webinars, please inform Sutep. So Sutep can always open the webinar as ELSA president.
Okay, sir.
We would always be honored for having Sutep.
Hello,
Hey, Sir
Bro.
Faras.
bro. I'm a participant. I'm
Sir
joining
Faras
you.
already.
Hey,
I'm here. Good to see you guys. Alan, you look
Hey,
amazing.
how are you?
Sutep.
No. You have to show me upside down way, huh?
Like this.
Something like that. I have your photo, huh?
Hindi, yung regular
I have
sa...
your video. I can show.
That's great to see you guys. How are you guys doing everywhere? Sutep, how are
I'm
you?
good.
How are you?
Bangkok is okay.
Yeah, it looks like you guys have crossed your peak and now slowing down. We are still catching up.
You will be good. No worry.
Yeah.
So, how's Calcutta? Is everything okay?
Yeah, so we are going to the hospital on a daily basis now. Today I took a leave because this is 11 o'clock, 11:30 in the morning for us. So that's why I took a leave today. But its hospital has begun as usual. The load is still less. It's still about 50 to 60% of what it used to be.
Okay.
And for the children, it is a bit of a problem because their school, they're all online. They're always in the house. That's not something good.
It's tough. Not for them. Tough for
Yeah.
us too.
Yeah, it's tough for us. The spouses have to deal with each other on a daily basis, minute to minute. It's like truce happening every 2 hours.
Exactly. But anyway, I
Yeah.
can see you very nice. Huh? I'm happy to see you here. Huh?
Same here, man. Really good to see you. I love your tie.
Oh, thank you. Thank you. Thank you.
Hindi sir. Tayo ba yung walang video card? Parang hindi yata.
So we need to start. Start na.
Anong charger mo dito? Separate? Ah.
Okay. Okay, mag-start na.
Start na daw tayo.
Bakit hindi ba tayo nag-start?
Hello.
Hi, Sutap.
Hi. How you doing? Huh?
Kevin, start na.
Sino ba ang first lecture natin?
Sinasabi ko na sa inyo. Kaya kaya dito.
I go check with my fellows.
Wait na. Hey, we need to start.
55 pa lang tayo, sir. Wala pala si
Kevin?
God bless whom? Is that Alan?
Yes.
Okay, so God bless you.
Thank you. Sorry.
Not at all.
Makabit na to, sir.
Let's start. Ikabit na, nakakabit na. I-hook na. Okay, we're starting in 1 minute.
Sure.
Yep.
Hi, Philip. Philipson.
Hello. Hi.
Hi, Philip. Thank you.
Hi,
Hello.
Philip.
Hi.
Good to see you.
Arlene, we
Everybody
start in 1 minute. Okay.
You have lunch? Have you have lunch?
I just
We
finished
did.
lunch.
Great,
So
great,
good.
great.
Huh? I do have durian. Huh?
Durian, I envy you.
Yes.
I had nothing. I am still waiting for my breakfast.
Wow, 11 already.
Yeah, no, I just go hungry today. Okay.
That's why you keep yourself so fit, huh? Slim. Not only the
No.
exercise that you have done.
Well, we keep on trying to do something new, more like a monkey business.
I love it. Huh? Please challenge every day.
Wala akong ano. Dapat tikman. Kaninang laptop? Nagamit sa computer yan. Arlene, start na daw. Habol na lang namin dito. Joel, okay ka na?
Okay, good. Anong link mo? Anong link namin?
Sa email niya.
Alam mo, hindi pwede kami nila. Start, ano sabi?
Naka-mute si Joel.
Arlene, nakamute ba ako? Arlene, nakamute si Joel. Arlene.
Good afternoon. Good afternoon. So let me start this afternoon's conference. In behalf of the Unified Minimally Invasive Training Program, I would like to welcome our participants from all over the globe, namely India, Myanmar, Singapore, Thailand, and Sulu. For this afternoon's conference, we will be discussing achalasia, which is an uncommon disorder that may be treated optimally via minimally invasive approaches. So for the opening remarks, I would like to call on our program director, Dr. Allen Buenafe.
Yes, sir.
Yes, good afternoon.
Wait naman.
Hello? Can you hear me?
I can hear you.
Yeah, good afternoon. I would like to, first of all, thank our speakers, Sir Faras, Philip Chu, Dr. Silvana Pereta for sharing their time and knowledge again for this conference, weekly conference. I would like to welcome everyone, all the participants for coming in and sharing this afternoon with us. I would also like to inform everyone that the president of ELSA, Professor Sotepodom Sawengsup, has been more than very kind enough to join us and would like to give the welcome address to everyone. Sotep, please.
Thank you. Thank you. Sawadee Club. Thank you very much, Alan. First, I would like to congratulate to the UMIST and also the PCAS as well as the Philippine colleague for the initiative of having the webinar among the fellows and participants. So thank you very much. And also we are looking forward to all fellows from Thailand also joining for this webinar. So as you all know that we are in the a bit difficult situation that we have to adopt and adapt some of our normal activities. So this is what we learned from also from the Philippine team. Anyway, thank you very much. As the ELSA would be very happy to have seen the society in Asia having the contribution in terms of the academic activity and collaboration. So without any delay, thank you very much. I'm looking forward to the speakers and the topics of Achalasia, which is one of my favorites, and as well as those participant favorite. Welcome to UMIST. Thank you very much.
Joel, let's start with the first lecture. Let's start with the first lecture.
Yes, sir. Joel, start with the first lecture.
Thank you very much, Dr. Sutep. Let's start with the first lecture. Yes, for Charlie Min Cabangal. He finished his residency training in general surgery at the Zamboanga City Medical Center and is currently the fellow in training of the minimally invasive program in Batangas Medical Center. So can we call on Dr. Cabangal to discuss the laparoscopic treatment of achalasia?
Assalamualaikum warahmatullahi ta'ala wal barakatuh, and welcome to our weekly conference. Again, I am Dr. Charlie Min Cabangal, your MIS Fellow under the Unified MIS Training Program. So for today's lecture, I will be presenting to you the laparoscopic approach in the management of achalasia. So for my disclosure, I have no disclosure for this presentation, but I would like to emphasize only that I am not an expert in this topic, but rather a learner and a seeker of knowledge. So for my objectives are as follows. I would be presenting a case of achalasia, its clinical presentation, and the paraclinical evaluation to achieve the diagnosis, as well as the management protocol. And in the management, I will be focusing on the laparoscopic Heller's myotomy and its postoperative care. So for our general data, we have patient RO, 25 years old male, who came in with the chief complaint of dysphagia, noted of about 12 months duration. So his history revealed that about 5 years prior to admission, there was noted on and off chest pain and regurgitation after meal. His condition was tolerated until about 1 year prior to admission. There was noted symptoms of dysphagia associated with episodes of coughing and weight loss. So this progression of dysphagia from solid to liquid food prompted patient to seek consult. On physical examination, patient was seen awake, not in respiratory distress, ambulatory, and with stable vital signs. The rest of the physical examination findings were essentially normal. So at this point, our clinical impression is esophageal dysmotility disorder, to consider achalasia. And among our differential diagnoses are diffuse esophageal spasm, gastroesophageal reflux disease, esophageal malignancy, and esophageal web. So initial laboratory workups, the CBC chest X-ray and the 12-lead ECG were revealed normal results. And then on further workup, a barium esophagogram was done on this patient, which revealed a dilated proximal esophagus with distal narrowing with constriction presenting a bird's beak appearance. So this presentation is suggestive of achalasia. However, since other disease entities like esophageal neoplasm and stricture could also present similarly, an endoscopic evaluation was performed, which confirms the findings of esophageal dilatation with retained food. A constricted lower esophageal sphincter was also noted with normal appearing mucosa. With this in hand, an esophageal manometry, which is the gold standard in the diagnosis of achalasia, was performed. The results showed a high pressure in the lower esophageal sphincter with non-relaxation on swallowing, coupled with the absence of peristalsis and panesophageal pressure, which is characteristic of a diagnosis of primary achalasia with Chicago classification type 2. So for my case discussion, what is achalasia is derived from the Greek word kalasis, which means to slacken or slackening. It's a rare disease affecting 1 to 2 persons for every 100,000 population. Primary achalasia is an idiopathic disease considered to be an autoimmune in origin. It's characterized by progressive degeneration of nerve cells in the Auerbach's plexus of the esophageal wall, resulting in loss of peristalsis and non-relaxing lower esophageal sphincter. So this failed esophageal emptying will then cause the myriads of symptoms manifested by achalasia. So about 90% would present with dysphagia and regurgitation. Difficulty belching has been noted in about 85% of cases. Substernal pain and discomfort has been noted in about 60% of patients. And other symptoms would include aspiration and weight loss, as well as foul-smelling breath. So symptoms-based evaluation like Eckerd scoring has been used in initially staging achalasia. However, it is found to be not sufficient since most other esophageal diseases have similar presentations. Hence, a detailed and more systematic study is needed to achieve an early and correct diagnosis, as well as help in the management plan and prognosis. So we have the barium esophagogram, endoscopy, pH, 24-hour pH monitoring, and the esophageal manometry among the evaluating procedures in the diagnosis of achalasia. So for the barium esophagogram, this is the capacity to diagnose 2 out of 3 patients with achalasia. It uses water-soluble contrast material. An esophagogram is a simple yet reliable way to evaluate the esophageal anatomy. It can diagnose, as mentioned, 2 out of 3 patients with achalasia, and using the Resende classification, it can be used to grade the degree of your esophageal dilatation. However, since early stage achalasia may not present with dilatation, and other diseases of the esophagus, such as pseudoachalasia, may also present with dilatation, a more invasive study is needed to aid in the investigation. So an endoscopic assessment can be performed in this patient, which will be further discussed by our next presenter. Another tool in investigating achalasia is ambulatory pH monitoring, which would differentiate an esophageal reflux from regurgitation, especially in patients presenting with chest pain or heartburn. And it was also indicated for investigation of gastroesophageal reflex in post-op patients. And lastly, the esophageal manometry, which would be diagnosing about more than 90% of patients with achalasia. This high-resolution manometry, or HRM, is the gold standard in diagnosis. So using the Chicago classification, achalasia can be differentiated between type 1 or classic achalasia, type 2, and the rare type, which is type 3 or the spastic achalasia. Moreover, Chicago classification is also used in predicting treatment response as well as treatment options. Type 1 and 2 achalasia has a treatment response of about 56 and 96% respectively, which would respond well with pneumatic dilatation and surgical myotomy, while type 3 or the rare spastic achalasia has a 29% treatment response, and it is best managed with per RM endoscopic myotomy. How is achalasia managed? So there are 3 major options that we can choose in managing achalasia. First is the pharmacologic therapy. Second is the endoscopic management, which is a non-surgical option, which would include botulinum toxin therapy and pneumatic dilatation. And lastly is the surgical management, which would include laparoscopic myotomy with partial fundoplication and the POEM. So here, I would like to show you the treatment algorithm for achalasia according to the American Society of Gastroenterologists. So patient with high surgical risk would be given or offered the option of Botox injection, followed by pharmacologic management. While patients who are good surgical candidates should be offered either pneumatic dilatation or myotomy. So pharmacologic therapy is indicated for a very early stage achalasia, and it is often used as temporary management prior to definitive management, and for patients also with poor surgical candidates. So it reduces the lower esophageal pressure by smooth muscle relaxation, and we have 2 medications that can be used for pharmacologic therapy. One is the calcium channel blockers, such as nifedipine 10 to 30 milligrams, and the long-acting nitrates such as isosorbate dinitrate. So I'm showing you here the advantage and disadvantages of pharmacologic therapy. So to note with its advantage is that it can decrease the LES pressure by 50%, and the nitrate would relieve symptoms in 53 to 87% of our patients. However, it would only last for 3 to 27 minutes. And nifedipine, on the other hand, would provide symptom relief in 0 to 75% of patients, but would only last for 30 to 120 minutes. So its disadvantage would include decreased efficacy during long-term use, and the relief is also temporary and short duration of action, and there is also incomplete symptom relief since the peristalsis of food or propulsion of food through the esophagus is not affected. The side effect also is noted to occur about 30% of our patients, which would include peripheral edema, headache, and hypotension. For the non-surgical endoscopic management, it would include botulinum toxin therapy and the pneumatic dilatation, which would be discussed by our next presenter. So for our surgical management, laparoscopic Heller's myotomy is considered the treatment of choice in managing esophageal achalasia. It is the most effective with least recurrence compared to other modalities. So here are the advantages and disadvantages of the procedure. So the advantage would include the symptom improvement in about 83% of our patients with a minimal pain, fast recovery, and short time off work with the laparoscopic approach. While the disadvantage would include the most common complication, which is the gastroesophageal reflux. So the Heller's myotomy, which was first described by Ernest Heller in 1914, the principle has been the same even if the approach have been modified or have improved all through the years. So it would include the dissection of our outer longitudinal muscles of the esophagus as well as the middle circular layer, exposing the inner esophageal mucosa. So during Heller's myotomy, an extended proximal myotomy of 6 centimeter cephalad from the EGJ and 2.25 cm towards the stomach is necessary to normalize the distensibility of the esophagogastric junction in achalasia. And since the incidence of post-operative gastroesophageal symptoms was clearly higher when no fundoplication was performed, so fundoplication is now a significant component of Heller myotomy in the management of achalasia. So this is the video of the procedure, the Heller's myotomy and the partial fundoplication. So the patient position is patient is positioned in a lithotomy position with legs spread in a stirrup, and then the surgeon stands between the patient's legs, and the assists are placed on both sides of the patient. So the trocar placement, we placed 5 trocars. The first is the camera port using the 10 millimeter trocar placed at the midline about 14 centimeter distal from the xiphoid process. The second and third port would be placed in the mid clavicular line at the level or slightly above the level of the camera port, which would be for traction and counter traction. And the fourth and fifth instrument port would be placed between the costal margins, forming a 120-degree axis angle. So once we are safely within the abdominal cavity, proper mobilization and identification of structure should be achieved. So the right gastrohepatic ligament is divided up to the level of the crus of the diaphragm and identifying the posterior vagus nerve. Similarly, on the left, the gastrosplenic and the phrenoesophageal membrane anteriorly is released, exposing the left crus, and the anterior vagus nerve is secured. The short gastric vessels are also divided on the left so that the fundus will be mobilized. And then superiorly, the esophagus is further mobilized from the mediastinum for about 6 centimeters cephalad. Take note that in door fundoplication, there is no dissection on the posterior aspect. So once identification and mobilization is achieved, we can now proceed with the myotomy. So from the EGJ junction level, the longitudinal muscle fibers are properly identified, and using a cautery device, it is identified and opened about 6 centimeters cephalad, as shown in the video. Then the myotomy is continued to the anterior gastric wall for another 2 centimeters, with a total of about 8 centimeter length of myotomy. Afterwards, the circular muscle fibers are identified and divided so that the mucosal layer will be exposed. So there, that's the circular muscle fibers. So here is your completed Heller's myotomy. An intraoperative endoscopy can also be used by intraluminally evaluating to confirm the extent of the myotomy. This could also be used to check for mucosal violation or perforation intraluminally. In some cases, bleeding may occur during myotomy, particularly in the muscular layer, and it is avoided. Cautery should be avoided since it may lead to thermal injury and perforation. And if perforation is identified, it should be repaired promptly using fine absorbable sutures with a 5-0 and an atraumatic needle, round needle. So once for the door funduplication, the partial anterior funduplication is the preferred option for this patient. So door funduplication is constructed in 2 rows of suture. So on the right, the uppermost stitch is would incorporate the right side of the esophageal muscle to the right pillar of the crus of the diaphragm. So there, from the esophageal wall, anchored towards the right crus of the diaphragm. That's another suture. The second row on the left, the uppermost suture would incorporate the pillar of the left crus of the diaphragm to the stomach and the left side of the esophageal wall. So the pillar of the crus, the stomach, and then the left side of the esophageal wall muscle. And then 2 more sutures are placed that would incorporate, that would anchor or put together the gastric fundus to the esophageal muscle wall. Next, the fundus is then folded over the exposed mucosa, suturing it to the greater curvature of the stomach, to the pillar of the right crus and the esophageal muscle wall of the diaphragm. I mean, the right crus of the diaphragm and the esophageal wall on the right. Additional sutures will be placed to fix the gastric greater curvature to the right esophageal wall and the right crus. And finally, the anterior rim of the esophageal hiatus is sutured to the superior aspect of the fundus to close the defect and to decrease the tension on the right row. So partial fundoplication can be done anteriorly, as described with the door fundoplication, or a posterior approach can also be used using the toupee technique. The Nissen fundoplication is contraindicated due to the esophageal aperistaltic nature of achalasia. Although toupee has been found to be better in long-term control of reflux, door is preferred over toupee because number one, it has a 93% effectivity in managing the symptoms. It has less dissection posteriorly and then less disruption of the hiatal anatomy. The procedure is relatively faster and easier compared to toupee, and it would allow a coverage and protection of the esophageal mucosa with the gastric fundus, which is especially important if perforation has occurred. So post-op complications have been reported in about 6.3% of cases with a low mortality incidence of 0.1% according to a meta-analysis done by Campos. So among the post-op complications, it would include post-op reflux, which occurs in 8.8%, or a range of 0 to 44% after fundoplication, and esophageal perforation during surgery can occur in 6.9% of patients with a range of 0 to 33%. Reoperation rate has been less than 5%, and a study by Wang et al. Revealed that the reasons for myotomy failure and reops were incomplete myotomy in 33%, fibrosis in 27%, disruption of the fundoplication in 13%, and tight fundoplication in 7% of the cases. So for post-op care, patients are usually fed on the post-operative day one and instructed to avoid meat and bread for 2 weeks. About 70% of patients are discharged within 23 hours, and 90% of patients are discharged within 48 hours. And most patients are able to resume regular activities in 7 to 14 days. For the post-op recommendations, for short-term assessment, patients are assessed for both symptoms relief, such as dysphagia, regurgitation, aspiration, and chest pain. So the long-term follow-up would include ambulatory pH monitoring. So pH monitoring is recommended since post-op patient has cases of post-op reflux in about 10 to 30%. And the time barium esophagogram and high resolution manometry are advised for patients who are symptomatic post-operatively. For instance, there is delayed in incomplete esophageal emptying since these patients are at high risk for relapse. Hence, TB and HRM are repeated annually. Surveillance endoscopy is for surveillance endoscopy, although there is increased risk of squamous cell CA and adenocarcinoma in patients with achalasia, the American Society of Gastroenterologists does not advise routine use or does not recommend the routine use of surveillance endoscopy since there are limited data to support its routine use. So this ends my presentation. Thank you and good afternoon.
Thank you very much, Dr. Cabangal. At this juncture, we would like to acknowledge the presence of Professor Silvana Peretta, all the way from Strasbourg, France. She will be discussing later on. And at this juncture, I would like to introduce the next speaker. He is Dr. Mark Artemio Reyes. He completed his general surgery training program at the Medical City, and he's currently the surgical endoscopy fellow at the Rizal Medical Center. He will be discussing per oral endoscopic myotomy. Dr. Reyes. Dr. Reyes, can you please unmute your microphone? Still no audio coming from you, Dr. Reyes. Can you unmute your microphone, please?
Dr. Reyes, you can check your audio settings in the Zoom panel.
Okay. How about this one? Do you hear me?
Yeah.
Loud and clear, Dr. Reyes. Go ahead.
Okay, thank you. Sorry about that. Okay. Once again, I'm here to present. I am Mark Artemio Reyes, a surgical endoscopy fellow of the Rizal Medical Center. And I'm here to present the case of a 65-year-old lady with a 6-month history of dysphagia accompanied by chest pain and regurgitation. Eckert score at the time of consultation was 6, which was significant. Initial management was done by gastroenterology. Upper endoscopy showed esophagitis from mid to distal portion, a dilated distal esophagus with normal to tight sphincter tone was noted. Antral erosions were also seen, and no tumors or strictures were appreciated. Achalasia was considered. Further workup showed smooth flow of contrast from the mouth to the esophagus, where there was a persistent narrowing at the GEJ on esophagogram. Pulling of contrast material in the slightly dilated and tortuous mid to distal portion of the esophagus was noted. Contrast flow to the stomach was still appreciated. This was signed out as consider achalasia. She was then referred to our service and management options were given. Patient chose endoscopic myotomy. For a little history, the earliest study I can find with regards to endoscopic myotomy was done by Ortega et al. In 1980. These were first done experimentally on dogs, then eventually applied to human patients diagnosed with achalasia. The objective was to alter the esophageal rosette involving multiple mucosal incisions directly at the Z-line to access and eventually cut the circular muscles using a modified needle knife. The results were promising. However, due to the limited space, visual control of the needle tip movement during myotomy was therefore impossible, and thus perforation or injury to the surrounding structures could not be reliably avoided. In 2007, Pastricia et al. Proposed to perform the myotomy through a submucosal tunnel. The experiment was done on pigs after their individual baseline LES manometries were taken. In this procedure, a submucosal tunnel was developed using a controlled radial expansion balloon through a mucosal incision after creation of a saline cushion. The circular layer of muscles were incised using either an insulated tip knife or a regular needle knife under direct visualization in a distal to proximal fashion. The mucosal defect was then closed using standard endoclips. They concluded that the procedure was feasible, safe, effective, and has the potential of being useful in patients with achalasia. In 2010, Professor Inoue published a case series on peroral endoscopic myotomy, or POEM, which was a refinement of the previous animal experiment. One improvement was the application of endoscopic submucosal dissection technique instead of using a balloon catheter to create the submucosal tunnel. The total length of myotomy was also determined in the study. They found out that a minimum length of 7 cm provided a substantially lower post-operative dysphagia score. Back to our patient. After medical clearance and informed consent, she was scheduled to undergo POEM. Please allow me to share to you this video. This was the initial EGD showing a tight LES, and on withdrawal, we were able to exhibit an esophageal rosette. Mucosal entry was planned at 10 cm proximal to the LES. A solution composed of normal saline, epinephrine, methylene blue, and hyaluronic acid was first injected into the submucosal space to create a cushion. A 2 cm mucosal incision was done using a dual knife to expose the underlying submucosa. Upon entry, spray coagulation mode was used for submucosal dissection. Concurrently, a careful inspection of the mucosa was performed to detect inadvertent mucosal tears. The tunnel is then extended approximately 3 cm distal to the EGJ to ensure complete myotomy of the LES. As the dissection approaches the EGJ, the tunnel becomes narrow. Once a submucosal working space has been created, a 10 cm long selected myotomy of the circular muscle was performed. In contrast to the initial EGD, notice that the LES is not as tight. Mucosal entry site was then closed using standard endoclips. Liquids were started 1 day post-op and progressed to solids the day after. Patient noted a relief from symptoms and was discharged improved. According to the latest Achalasia guidelines, POEM had similar outcomes on swallowing functions when compared with hilar myotomy or pneumatic dilatation. It has also been cited that POEM had superiority in managing patients with Chicago type 3 achalasia because of its ability to extend the myotomy further into the thoracic portion of the esophagus compared to the hilar myotomy. However, comparing with the previously mentioned therapies, POEM was associated with a higher incidence of post-myotomy GERD. This led to the development and addition of endoscopic fundoplication in some centers. The guidelines also stated that POEM is an appropriate treatment for recurrent achalasia after the failure of an initial intervention. That's the end of my presentation. Thank you and have a good day.
Thank you very much, Dr. Reyes. For our participants, I would like to remind you that please reserve your questions for later, and you can type your questions in the Q&A portion in the Q&A box found below. And also, I would like to acknowledge the presence of Dr. Carlos Ejercito Jr., one of our panelists, coming from the Asian Hospital Medical Center. So for now, we move on to the tips and tricks as told by our experts. First, we have Dr. Sarfaraz Baig, coming all the way from India. Sir, good afternoon. He is a gastrointestinal, minimal invasive, and bariatric surgeon. He is a director of digestive surgery from the Bellevue Clinic in Kolkata, India, and he is also an active member of the ASI, the IASG, IAGES, the AMASI, IASO, OSSI, and IFSO. There's a lot of letters. Yes. Thank you very much and welcome, Professor Baig.
Thank you. Yeah. So thank you very much. I think we had two great presentations, and it has actually made my job easier. Uh, it has made my job easier because now that we have laid the platform of talking about the laparoscopic as well as the medical management of achalasia, I will probably be injecting some sort of wisdom from our experience and from the published literature as to how a surgeon could tread these waters very carefully. Remember, now we are not in the same age as we were there 20 years back. We are in an age where the options are improving, patients are getting well informed, and therefore there is a huge area where there is a lot of counseling and patients can actually exercise their choice. We need to be careful how we word ourselves and how we choose our patients. So this is going to be the essence of my talk. This is the beautiful hospital that we talk about, Bellevue in Calcutta. That's my team. The first disclosure I would like to say is, since I do not do poem personally, my medical colleague does it. Therefore, I have no idea about the skipped heartbeats and the learning curve that that gentleman has gone through. Therefore, I think that's a very important disclosure, because I do understand that this particular procedure does have a learning curve and there's a lot of things to be understood. So from a surgeon's perspective, what can I tell you? I will be dividing my talk about in four aspects. I'll talk a little bit about a disease, maybe about a minute, case selection for about 3-4 minutes, technical tips for about 5 minutes, and another 2-3 minutes on the follow-up. So that's going to be the outline of my talk. It is a good idea to remind ourselves on a regular basis that when we talk about achalasia, we are talking about a primary motility disorder of the esophagus, which is progressive and chronic. Our purpose is not to cure this disease. Our purpose is to palliate this disease. Just like any other chronic disease, we do not know the actual cause, and hence our treatment has not been perfect. It has been suboptimal, to say the least. As a surgeon or a medical guy, our treatment is to reduce the LES pressure in a broad manner of speaking. Of course, we have gone a little ahead with the Chicago classification, with the manometric studies coming in. We're improving, but our basic purpose so far with esophageal motility disorders are, we are trying to identify the LES hypertonia, and we're trying to reduce it with a variable length of cardiomyotomy. Let me talk about, as a surgeon, what is the kind of cleverness that I use in our practice so as not to take the wrong patient and so as not to give a poor outcome. I would like to draw your attention to this meta-analysis published in 2020, actually got in 2019, but published this year. And it is an important paper because it tells all of us, the medical gastroenterologists, the surgical gastroenterologists, what kind of patients do not do well with our treatment. Type 3 achalasia, the spastic variety already mentioned by my previous speakers so well, they do not do very well. 2, the elderly population do not do well to treatment. And third, the ones with dilated tortuous esophagus, they don't do well to our treatment. So in my practice, it is important for me to realize that I am going to identify the elderly group of people who on their esophagram have shown a dilated and tortuous esophagus. They probably have been getting treated for years. And third is the type 3 achalasia. These are the ones that I'm wary about to take them for surgical therapy, because or for that matter for any therapy, but surgical therapy in particular, because no matter what I do, they're not going to have a great outcome. About a decade back, I used to think that if my manometry endoscopist, they're giving me a great report, I do not need to see the pictures. And I couldn't have been further from the truth. And I would like to impress upon everybody who is watching this that the most important thing that I've learned in the last 10 years in achalasia is that I need to read my manometry myself. And I need to interpret it better so that I can make the right decisions. The first thing is that we must be able to identify a normal manometric graph. If we look at these HRM colors, we know that the blue is low pressure, red and magenta are high pressure. With that in mind, and understanding that the dip up here is the upper esophageal sphincter, and at that same time, the fall in pressure lower down is representative of IRP, the integrated relaxation pressure. Now, I'm not going into the details, but it is important to understand that the fall in the pressure at the same time at the lower esophagus, at the time when there is a swallow, and when there's at the same time when there's a dip in the upper esophageal pressure, that is the IRP. It's a little more complex than that, but let's say that's the IRP. So the other thing that we need to know from the graph is what is the peristalsis. So now we know the LES pressure. Is it more than 15, less than 15? Is the IRP more than 15? Okay, then it's a hypertonic LES. The second thing I need to know is the peristalsis. What is a DCI? What is a DL? Now, DCI basically means the pressure generated in the distal esophagus. As you can see, the red and magenta core here, and the yellow and green surrounding, that's the smooth muscle component generating pressure in the lower part. Now, if these pressures are very high, that's a spastic esophagus. It could be a jackhammer. So that is the problem area. And if you look at the DL, which means distal latency, it is a time taken from the upper esophageal sphincter relaxation to the point that the bolus has come to the smooth muscle component. And if that is more than more or less than 4.5 seconds, then it means something. So peristalsis, I need to assess the DCI and the DL. And for LES sphincter, I need to see the IRP. Now, with that in mind, let us see what the Chicago classification means. It has been touched upon by the previous speakers, but as a surgeon, what does this mean to me? Well, it looked like a lot of tram lines and railway lines to me initially. It is pretty confusing. I stayed away from it. But I realized as a foregut surgeon, we need to understand the Chicago classification in depth. Now, 1 and 2 Chicago means that the IRP is elevated. If the peristalsis is also bad, it's type 1. If the peristalsis is okay, only the IRP is elevated, is Chicago 2. So Chicago 1 is achalasia, which can be subdivided into 3 components depending on whether there's absent peristalsis, a panesophageal polarization, or a spasm. Whereas type 2 Chicago is very important because it means that the peristalsis is fine. It's just the IRP is more than 15. And this is a very important subset, and I'll be speaking a few lines on it just in a while. But frankly, these are the 2 types that a surgeon is interested in, Chicago 1 and Chicago 2. As soon as I get a Chicago 3 and a Chicago 4, 5 being the normal, 3 and 4 have normal IRP, which means there is no hypertonia of the lower esophageal sphincter. It's a peristaltic problem. The DL is abnormal, or there is a high DCI, or there is an ineffective swallow. And these belong to the domain of my medical colleagues. So as soon as I see a Chicago 3 and 4, I call up my medical gastroenterologist friend and say, and I'm sending this motility disorder to you. So of course, I will leave it to your own judgment, how you do your own practice, but let me go through what we've learned. So as a surgeon, I realized I can treat a hypertonic LES. So these are 2 varieties. Let me go into a little bit more depth so that we can choose our patients better. When we look at type 1, type 2, type 3, and these are pictures which most foregut surgeons are so well versed with, but for the sake of people who are joining in and who do not know much about the manometric studies, type 1 is the one where in all the types, you will see the IRP is higher than 15. So it's 18.4, 33.7, and 26.4 in 1, 2, and 3, the graph shown here. However, if you look at the peristalsis, it's all different. In type 1, there is absolutely blue. It's blue all over. There's no pressure being generated. It's just like a free fall of the bolus from the upper esophagus to the lower esophagus. Whereas in type 2, there is some sort of a polarization right from the top to the bottom. There's some effort of peristalsis there. And in type 3, the distal esophagus is trying to make a pressure very high to overcome the hypertonic LES. Now, you might think that type 1 is the early achalasia and type 3 is the late achalasia. It's just the reverse. type 1 is the advanced achalasia and type 3 is the early achalasia. And therefore, with that in mind, I would like to make people appreciate that as a surgeon, type 1 and type 2 are good to take up for a cardiomyotomy, Heller cardiomyotomy. But a type 3 goes to my friends for POEM. There has been enough literature now. This is the one which I quote most frequently, which showed that the clinical success between POEM and Heller myotomy in type 3 is better with the POEM, 98% versus 80%. And even adverse events wise, it is better. Now, that's probably because in a POEM, our friends can do a very longer myotomy compared to the Heller. And I will also like to attract your attention to this meta-analysis, a very important meta-analysis published in 2019, where they showed that type 3, of course, it works inferior, but even in type 1 and type 2, in type 2, it is comparable, Heller's and POEM. But in type 1 also, POEM probably works better than Heller. However, as a surgeon, and I'm trying to put up this for my colleagues coming after me, that even in type 1 and type 2, both the Heller's works well, not only because the efficacy is comparable in type 1, probably POEM works better, but as far as adverse event profile is concerned, in terms of GERD, Heller's is a little better than POEM, and therefore in our practice, type 1 and type 2 get a Heller's if the patient is agreeable. Before I leave you with the Chicago 1 only, I want to touch on Chicago 2. Chicago 2 means that there is an esophagogastric junction outflow obstruction, which means the IRP is high, but the peristalsis is normal, as you can see these two. However, I do not leave these patients in immediately for my medical colleagues. Rather, what happens is I tend to evaluate them further because this may mean advanced GERD. There may be a reflux phenomena causing a hypertonic LES because of a mucosal stricture or a paraesophageal component, and therefore I need to evaluate this with endoscopy, a CT probably. So these patients get further evaluation in my hands. Also, these patients could also be an inadequately expressed achalasia. It's an achalasian evolution. So we need to, again, put these patients under surveillance. So these patients actually get a joint effort between me and my medical colleague. What about the technical aspects? Now, in technical aspects, I'd like to take you through a teaching video. Dr. Joel, just tell me if this video is playing properly. Otherwise, what I'll do is I'll go out and then get my play it outside the presentation. It's all right? Okay, great, Dr. Joel. Thank you very much. So the first thing is that what we do is the retractor goes in. We don't like manual retraction, and we do an inverted J hockey stick incision. We start with the gastrohepatic. There will be some repeats of the previous video, but I would still like to put in my points that we have learned how to do a cardiomyotomy. And this same incision is carried on the other side continuously. We're cutting the anterior phenoesophageal membrane, something that may be augmenting the reflux, and then going on the opposite side to see the left cruise. So the right cruise, anterior phenoesophageal, and seeing the left cruise. So the dissection is like a hockey stick first. Then this is a cardiomyotomy with a door. Where do we do it? I will come to that a little later. And what I'm doing is I'm trying to build space in the anterior part of the esophagus, not disturbing the posterior here, and going right to the top in the mediastinum till I can purchase about 7 to 8 centimeters out there. And now I can see the two pillars, the left and the right cruise. Now, why I do this, the important thing is to realize how much of esophagus is within the abdomen. If you find there's not enough length of esophagus in the abdomen, or you may have a suspicion because of a pre-existing endoscopy, you may be happier doing a toupee here. But this patient is good enough for a door. So what are we doing here? We have done the incision, we have done mediastinal dissection. We are just trying to mark where the left gastric artery is. And that is why this small dissection, this nuance that we do, it's important for us to realize how low are we going to go on the stomach. And that's the problem with both POEM and Heller's. Even so many years later, I still skip a heartbeat when I'm doing the lower part. And I see my medical colleague having the same problem with doing POEM. So now we are going to start the cardiomyotomy just above the GE junction. And here, what our practice is, we have seen the usage of a hook beautifully by our previous speaker. What we do is we have a blunt-tipped Maryland dissecting forceps. And with that, we split the longitudinal muscle. You can see the gauge pieces lying there. We have not used any energy source yet. Then we take a reverse of an ultrasonic shear. The reverse, the active blade is away from the mucosa. And then we go bit by bit. The suction and the blunt tip Maryland makes the dissection, and the reversed ultrasonic shear takes the fibers. And this way we try to create a well-visioned, well-visualized cardiomyotomy which goes to the top. Now there will be some nuances which I'll come to a little later, but you can see what we are doing here is we've been following this. We have done blunt dissection with 2 Marylands. We have tried ultrasonic shears, we've tried hooks, but what works is this for us. And we try to keep the hot electrode of the harmonic every time to the gauge pitch which is wet, which basically decreases the temperature of the hot ultrasonic shear, and that's something which we do. Another small thing, we are dissecting the fibers, the longitudinal fibers, away from the mucosa. That distance that we are giving will ensure that this cardiomyotomy does not reverse itself over a period of time. Now, I'll go a little ahead. Let me see if I can for the sake of time. Yeah. Now, we are at the bottom part of this incision, and this is the part I was talking about. Whether it's poem or a Heller's, the problem is not the esophageal side, it's always the stomach side. And here we need to exercise some sort of experience. So what we do is we use a hook at the lower end, and this is what we have realized, that here at this area the harmonic doesn't work well. So we take a hook and we go bit by bit, we score it so we know how low down we have to go, and then we connect from the point that we want to go from the stomach side right till the top. So that is one very important thing that I want to communicate through this video. Also, the assistant's job is a very important job here. It keeps the stomach hanging towards us from one side. So I am not looking at it from the top. I'm looking at it from the right. It's looking like a curtain falling in front of my eyes. And that is how we make a straight line. The oblique fibers of the stomach do create a problem. Now that you see, that is an oblique fiber. So identifying these fibers takes time. It is a learning curve, just like any complex surgery you would expect to be, and it takes time to realize how much you need to go in. At this juncture, maybe if I had an endoflip, I'll be happier. But the place where I live in, I do not have an endoflip. I do not see that happening in the near future also. So that's a cardiomyotomy, and then we add a door to it. Again, for the sake of time, I'm just going to go ahead. And probably show you just one stitch. I think what has been shown earlier is perfectly all right. So if it works, it works. Yeah. So using ethibond suture is something that we do. And this is how we think we tend to do. We did not do like Dr. Charlie showed us. I tend to take the same stitch with the crural pillar so that I do not need to over stitch or use more time to do those stitching. But I am sure that's perfectly legitimate way of doing it. So again, using this ethibond sutures helps. It's different color, it's braided, it stays there very well. And the final picture is something like this. Yeah. So here you can see I'm taking the crus as well as the divided longitudinal muscle together. So it saves a little bit of time there. And that's how it finally looks. So that's the door. This is the cardiomyotomy with toupee, but for the sake of time, what I will just show you is the initial part, that in some cases you do not have enough length of abdominal part of the esophagus. There's a hiatus hernia as well. And in these cases, we tend to use a toupee because in a toupee, we do a circumferential dissection. We can bring the esophagus down and then we can combine it with the cardiomyotomy. So I think a toupee versus a door, it could be an interesting debate on that, but our thought process based on some literature and our experience is that if we do like this, then we can deal with some patients who have an associated hiatus hernia. And of course, with the toupee, our experience has been that we have been able to manage with a longer cardiomyotomy. So coming to procedure selection for our surgeon friends, interestingly, for every truth, there's an equal and opposite truth. And this is no exception. In 2012, a very important paper by Sonstrom's group showed that the toupee is better than door when you compare the PH study in the postoperative period. And it stands to reason also that the toupee would be a better anti-reflux procedure than the door. However, in 2018, another group showed that the door is better than toupee, and that's counterintuitive, and I do not know how to explain that. Our protocol has been that if there's an achalasia with a hiatus hernia, we do a Heller with a toupee. If it's an achalasia with enough length of esophagus in the abdomen, no hiatus hernia, Heller door is better. Mucosal injury, Heller door. And this is something which I want the junior colleagues and everybody watching to take home. That's the Achilles heel of a door fundoplasty, of a Heller cardiomyotomy. Here, I have not dissected and I've introduced my ultrasonic shear. What does it do? It creates an esophageal perforation, something you don't want to see. The right thing to do is dissect first, the right plane. Do not use an energy source till the plane has been dissected. If you use an energy source before the plane, and I've done that twice in my life, so now I write this down for all everybody, going in a residential program. So this is what we have to do. And what needs to be done for treatment is, I tend to put in not vertical sutures, but horizontal sutures, A. 2, I tend to use 3 or 4 PDS. Leak test is something that we always do. And in these patients, doing a door fundoplication is a must. So this is what we do for a perforation. Now, the last part, the follow-up. And I think the success of a procedure is inversely proportional to follow-up. The harder you look, the more problems you find with your own treatment. And I think most of us would agree that although there are many ways of following up, but Eckhart score, endoscopy, and PH study is something that most of us use. We've added esophagram in our armamentarium, and we use manometry as and when required. Endoflip is not with us, but these are the methods of following up a achalasia patient after treatment. And I'll just touch upon a few things which I would like to say. Eckhart score has been touched upon, so I'll not speak about it. Esophagram is something that the Cleveland Clinic published earlier, suggesting that there's a correlation between the esophagram and the type of achalasia. So you can see the height and width is higher with type 1. Height and width, the width is narrower in type 2, and height and width both are shorter in type 3. And in the follow-up, they showed that reduction of this height and width by 50% is something that you would expect in a successful treatment of achalasia. And this is something that I am sharing with you because in India, we have a problem with resource. And I'm sure in Philippines, again, there will be lack of resource. And therefore, we've been using this kind of esophagram in patients who we cannot subject to endoscopy and pH study. Dysphagia is something that we get in some of our patients. The commonest cause is incomplete myotomy, but the tight wrap cannot be excluded. And good evaluation would be of paramount importance in these patients. We've been a great advocate for using POEM in these failed Hellers. And in the recent times, a good publication has shown that they have a success rate of 80%, which is inferior to what a primary POEM does, but still good enough for us. GERD has been the most common topic talked about in a treatment of achalasia. This is one paper which, again, most of us quote, showing that the POEM, although shows equivalent symptom response in terms of GERD, but in terms of endoscopic findings and pH study, it is inferior to the Hellers And there are many other studies which have shown this in a way to a variable degree. Our take has been that if there is a GERD after the treatment of achalasia, we try PPI, and we evaluate them thoroughly. And if it's post-POEM GERD, we think of adding fundoplication if this patient is not responding to PPI or they require PPI for a long time, because I do not believe that long-term PPI is safe anymore. And post-Hellers, if they are having GERD, I would like to actually evaluate them very, I would like to exclude a hiatus hernia. I like to exclude so many other things. And maybe in rare circumstances, I might like to convert a DOR into a two-pay fundoplication. And the end-stage achalasia is something a surgeon would never like to see. Nobody would ever like to see. Pneumatic dilatation and POEM in our hands, and we refer them to our thoracic colleagues for esophagectomy, which has shown to be effective. So finally, a take-home message from this talk that I would like to give from a surgeon's perspective is, if you realize that achalasia is a chronic and progressive disorder and we're not able to cure this, that would be one good message that can be shared. A Heller with partial fundoplication gives good results in type 1 and type 2 achalasia with acceptable GERD outcome. A POEM is better for type 3, so when you get a type 3, just send it to your medical colleague. Follow-up is key. The harder you look, the more problems you'll see. So another way of looking at things is don't look that hard, but that wouldn't be right and fair to the patient. So do the Eckhart score esophagram in a poor resource setup. Endoscopy, yes, PS study more and more advocated. Manometry as and when required, and endoflip if you have. And post-Heller dysphagia would need evaluation. In our hands, the most common cause is incomplete myotomy, and POEM is the way to go about it. GERD is seen after treatment of achalasia, and it's more after POEM, it seems, with literature as well as from our experience. We put them on PPI, a good thorough evaluation is done, and more often than not, at least in POEM, they require a redo fundoplication. And again, I would like to reiterate my talk with the last sentence that in procedures, especially in diseases which are chronic and progressive, and in treatment which are many times suboptimal, the success of a procedure in a chronic disease is inversely proportional to the follow-up. Thank you very much.
Thank you very much, Professor Sarfaraz. Very informative discussion, and a lot of tips were relayed to us. I hope we all inculcate your lessons. Next up, we have Dr. Philip Chu.
Hello. Hello. Okay, so let me share my screen. Can you see my slides? Okay.
Yeah, yes.
So I'd like to start. So thank you very much, and I'm very delighted to share with you the endoscopic perspective on management of achalasia. I'm from the I'm actually a surgeon working in the Department of Surgery, Chinese University of Hong Kong.
วันอาทิตย์เหรอเดี๋ยวกี่โมงดี
Okay, so right, so
โอ้ต้อง
achalasia
ประเมินรา
was
คาแล้วกันไม่น่าง่าย อาทิตย์เดียว
okay, some voice. Okay, so achalasia was first recognized 300 years ago. I think this is every expert would agree that this is a rare benign disorder of the esophagus. Incidence ranges between 0.3 to 1 per 10,000. And the Greek term typically describe achalasia as a failure of relaxation. So arguably the first report for treatment is in fact a passage of a curved whalebone with a sponge for a distal end dilatation of the esophagus. I think previously there's already speaker that cover the treatment option for achalasia. To me, pharmacological treatment is not effective at all. So I would think that endoscopic or surgical treatment will be the option. And Of course, surgical treatment, including halomartomy, but for end-stage achalasia, sometimes we even need to treat it by esophagectomy. Endoscopic treatment would generally include Botox injection, pneumatic dilatation, and I think POEM is a surgical endoscopic treatment. I'd like to cover the pneumatic dilatation because the previous speaker already described that Botox injection will be reserved only for those who are not fit for GA. And so for pneumatic dilatation, I think the advantage is that can be done under IV sedation. It performed by using the achalasia balloon that comes with a size of 30, 35 to 40 mm. And generally, we apply the pressure around 8 to 10 psi. And the objective is to break the LES with the radial force applied. And usually, we perform the dilatation under fluoroscopy. So this is kind of a process of the pneumatic dilatation. Initially, we pass the achalasia balloon and then observe for the wasting. And afterwards, after the procedure, we'll see a complete absence of the wasting. In the past, the team from Chinese University of Hong Kong, our team, reported a retrospective review of pneumatic dilatation for achalasia in 66 patients and published in endoscopy more than 15 years ago. The overall 5-year success was 74%, while for the 10-year outcome, it drops to just 62%. And another cohort study with a median follow-up of 13 years also showed that the long-term results of pneumatic dilatation for achalasia will not be that satisfactory. The 5-year remission rate is only 40%, and the 10-year remission rate was down to 36%. And we also compare results of pneumatic dilatation against laparoscopic halomartomy. And you can see that the incidence of recurrence of dysphagia was a little bit higher for the pneumatic dilatation, while the reintervention rate was significantly higher by the use of the pneumatic dilatation. So ultimately, I believe that most of the faculty over the last 10 to 20 years would consider halomartomy being a superior treatment as compared to pneumatic dilatation. So it's been reported by Heller in 1913. The initial description is a longitudinal cut of approximately 8 centimeter on bilateral esophageal wall that includes 2 centimeter cut on the distal part and a short cut over the cardia of the fundus. I think nowadays nobody will do bilateral myotomy for the halomartomy. However, I think the description is still valid. And of course, as covered by previous speaker, the performance of Heller cardiomyotomy and the incidence of having GERD after the Heller, so frontal pagation should be performed as a routine. Meanwhile, for halomartomy, we still need 4 or 5 incisions to perform the myotomy. So would it be a possibility of performing a myotomy without a scar? So Professor Haruhiro Inoue, which also happens to be my mentor, he performed the world first POEM procedure on the 8th of September 2008. So this is the first clinical report on the series of 17 patients who received a POEM with excellent outcome. And this actually leads to the development of what we call a third space in endoscopy. So reported in this editorial by Maureen Kusab. And from the endoscopy perspective, if the lumen was known to the endoscopist as the first space and the peritoneal cavity as a second, then the intramural space between the mucosa and the muscularis at the submucosa can be considered as the third space. And now we have a lot of surgery endoscopically performed but through this third space. For the POEM, which marked probably the very first procedure, the POEM is now performed at the endoscopy suite at our university. At the very beginning, we perform it in the OT, but now you can see that this is our endoscopy suite, which is equipped with a general anesthetic machine and also endoscopy machines mounted on the pendant. So it is very feasible just perform at the endoscopy center. The instruments that we use generally will include the TT knife with a water jet function from Olympus company. So there are other experts using the hybrid knife as well. These are the two most commonly used device. The endoscopic energy platform that we use is ERB 300D and or the ESG 400. In general, we inject only saline with indigo carmine without epinephrine. So this is the common setting that we have for the POEM procedure. So there are other accessories needed. For example, the endo clips that are required for closure of the mucosal entrance. CO2 insufflation is essential to avoid gas-related complication. The distal attachment, many experts use different kind of distal attachment, but for me, I just use a short cap of 4 mm in the length. Coagulation grasper is also necessary in case there's a bleeding. So this is one of my procedure of a POEM. So after mucosal incision, which is generally at around 10 centimeters above the GE junction, we then started to develop the submucosal tunnel. So the submucosal tunnel is very close to the muscularis propria, and we avoid damaging the mucosa. So that's why we stay close to the muscularis propria. And this is the typical dissection with the TT knife. And if necessary nowadays, we can inject through the TT knife of normal saline and indigo carmine. So we use the spray coagulation mode for the dissection, and that would enhance the passage of the diaphragm within a confined space. So, and when we encounter some blood vessel, usually we would coagulate before we cut. And we need to develop the tunnel all the way beyond the tight G junction to the gastric cardia. So how do we recognize when we pass the gastric cardia? Firstly, we can look at the mucosa for the palisading vessel. Secondly, we recognize the so-called spindle vein over the muscle side. And the third is that we can also recognize the difference in the muscle pattern. So this is the area of the tight GE junction. So you can see there's a lot of inflammation and the fibrosis which is typically happen. After passage, there will be a different kind of muscle fiber that we recognize. And also upon observation after the completion of the tunnel, we observe at the cardia that the mucosal bulge of the blue color reaches the gastric cardia. And afterwards, we started our initial dissection. For me, my practice is only focusing on inner circular myotomy. I will not do outer longitudinal because I think everybody would agree with me. The pathology comes from the inner circular muscle fiber. So if we cut the inner circular muscle fiber, we can achieve the alleviation of the symptom without the necessity of having a full thickness myotomy. So that would also reduce the chance of bleeding or even gas leak during the procedure. And my usual dissection area will be over the anterior side at a 1 o'clock position. There are experts doing the posterior myotomy as well. So this is almost passing beyond the tight G junction. So as you can see, I always use a coagulation mode for most of the myotomy in order to avoid bleeding. And this is a complete myotomy at the gastric cardia. So sometimes we also can be able to observe the peritoneal side structure or the peritoneal fat. So now we can see that the G junction is relieved, and most of the outer longitudinal muscle fibers, sometimes they will be split by the passage of the scope. But with the integrity of the adventitial layer, then there will be minimal gas leak. And we also avoid infective complication. So after completion of this myotomy, then we would have to close the mucosal entrance. So you can see that the G junction is now widely open, and the tight G junction is relieved. And the final part is closure of the mucosal entrance. So by endo clips most of the time, and we have to apply the clip from the distal end to the proximal end. So after the first clip of application, then all the other clips will follow the first clip. And as you can see, very importantly, we have to observe that we can approximate the two edge to avoid leakage at the mucosal entrance sites, and make sure that you be able to grasp the two sides of the mucosa. So this is the final clip. So we have started our POEM procedure in 2010. So now it's 10 years after the first procedure, and we did actually more than 350 cases of POEM. And this is one of our comparison between a injectable knife versus non-injectable knife, showing you that in general, our procedure time is shortened by the injectable knife. And now the average time is around 90 minutes, and the tunnel time is 38 minutes, while the myotomy time is 22 minutes. Hospital stay is 3 days, and there's no difference between the two groups in terms of the complication. And the ACTIS score before and after the POEM procedure have significantly improved, and you can see that there's no difference between the two groups. And also the ILP4 after the POEM procedure has significantly improved also. So in general, in our cohort, the occurrence of GERD is 22%. The overall recurrence rate of the achalasia is only 5%. And this is also a recently published data from Japan about a multi-center retrospective cohort study. And you can see that the clinical symptom response was 95% after POEM procedure at 3 months and 94% at 12 months. The adverse event occurrence rate was only 3.7%, while for the symptomatic GERD, it's around 15% occurrence rate. So how about a comparison of a POEM against pneumatic dilatation? So this is one of the most recent published randomized control trial, which we are part of the participating center, and this leading center is from Amsterdam, UMC. And this is a randomized trial comparing POEM against pneumatic dilatation for treatment of achalasia. So we recruited 67 patients in the POEM arm and 66 patients in the pneumatic dilatation arm. And finally, 64 patients received a POEM and 66 received a pneumatic dilatation. There's no difference in terms of the baseline demographics, age, weight, BMI, and also the achalasia subtype. So this paper was published in JAMA, and this is a very nice picture summary of the paper, showing you that the primary outcome is treatment success as defined by ACTIS score of less than 3. And you can see that 92% of the POEM procedure patients received a treatment success as compared to 54% of the pneumatic dilatation patient. And there was a significant difference of almost 38%. So when you look into the time analysis, the Kaplan-Meier curve also demonstrated that at 24 months, there was a significant difference in terms of the treatment success between POEM against pneumatic dilatation. And also, when you look into the reflux esophagitis, then you can see that the POEM have a significantly higher rate of endoscopic evidence of esophagitis as compared to a pneumatic dilatation at 1 year and also 2-year follow-up. And I think the previous speaker already mentioned that the POEM is a good choice of treating type 3 achalasia. So this is a video to show you multiple constrictions that we can see when we pass the endoscopy for a patient with a type 3 achalasia. So, and very important when we are treating patient with type 3 achalasia with POEM, we need to correlate the mucosal entrance and also the length of the myotomy with the endoscopic pneumatic, with the HRM finding. So we need the manometric finding so that the endoscopic measurement of the proximal mucosal entrance will be above all these constrictive constrictions of the muscularis propria. And then we develop a very long submucosal tunnel all the way down to the gastric cardia, same as the Bowen procedure. And then we perform a very long myotomy. So like that. So for this video, this is a posterior approach. So we choose at the 6 o'clock position, and then we perform the myotomy all the way down. So the advantage of having the posterior approach is that we can actually align the instrument channel better to the dissection plane. But the disadvantage is that there will be some fluid pooling over the 6 o'clock because the patient is in a supine position. Okay, so I think that I can skip this video. And as quoted before, this is a publication that we are one of the center participating in this retrospective study, demonstrating that the POEM have a significantly longer length of myotomy as compared to HeLa, and also a shorter procedure time, and with a better clinical response as compared to laparoscopic HeLa myotomy for type 3 achalasia. And the other advantage of POEM is probably to manage failure after HeLa myotomy. So when we are doing a HeLa myotomy, generally we select to perform it over the 1 o'clock or 12 o'clock position over the anterior side of the esophagus. But for POEM, we can select to perform over the posterior side. So that would be able to salvage a patient with HeLa myotomy with recurrence of the symptom. So this is one of the video that showed the development of, after development of tunnel, the salvage POEM procedure for a HeLa myotomy patient. So in here, there is a area which do not have absence of muscle fiber. So this area represents the previous HeLa myotomy site. So we just cut over the other side and then continue the myotomy. In general, from our experience, the reason for failure is the incompleteness of the myotomy over the gastric cardia, typically from the previous transthoracic HeLa myotomy. So we just extend the myotomy all the way down to the gastric cardia. And this is again a comparative trial published in the CGH 2017, comparing the clinical success for treatment of patients with previous HeLa myotomy as compared to those without. And although the clinical success was lower for patients who have a previous HeLa myotomy, the safety profile of POEM is comparable between the two groups. So it's still an acceptable option for managing the patient after failure of HeLa myotomy. So how about the management of GERD after POEM? So this is a recent systematic review about the GERD symptoms occurred after a POEM procedure. And you can see that the pooled rate would be at 90%, and as compared to a 8.8% of GERD symptom after laparoscopic HeLa myotomy. So in general, there will be a higher chance of the GERD symptom after the POEM as compared to HeLa. And the abnormal acid exposure is also higher for POEM as compared to HeLa myotomy. And the endoscopic finding of reflux is again higher for the POEM as compared to laparoscopic HeLa myotomy. And how to firstly prevent or reduce the incidence of GERD after POEM. So in general, there's a significant difference between the cohort study in the Caucasian country as compared to the Asian country, especially those from Japan or from us. Actually, the GERD occurrence rate is only 15 to 20%. So one of the reasons is because of anatomically, we try to avoid cutting into the collar sling fiber. So this is a recent report from Japan. This is now called the Tanaka two-vessel observation, where at the gastric cardia, you can see that there are two vessels that penetrate from the muscularis propria to the mucosa. And to the left of this two vessels. In fact, this is the collar link fiber. If you cut the collar link fiber, there will be much higher chance of having GERD as compared to those with a preservation of this collar link. So as demonstrated in this study. So very importantly, same as surgery, we have to recognize the anatomy and try to avoid damaging too much of the anti-reflux mechanism at the gastric cardia. And of course, there are new developments from Professor Haruhiro Inoue about the performance of fundoplication after POEM. So this is a recent report in endoscopy video from Professor Inoue showing you how he actually performed the fundoplication. So after the submucosal tunnel and the myotomy, he actually passed the endoscope through the incision over the peritoneum and grabs the anterior surface of the gastric fundus by using the clip and the loop technique. And after application of the clip and the loop, then he tightened the loop so that the fundus will be pulled to cover the myotomy site. So as compared to a surgical fundoplication, this is a little bit clumsy and probably difficult to appreciate, but this is probably one of the innovative idea that we can actually perform a fundoplication to avoid the occurrence of a acid reflux after the POEM procedure. So there are controversies as well how we should actually pull the fundus or how we should fix the fundus. And there are new devices coming up like an endoscopic suturing device that may help to fix the fundus to the myotomy site. And secondly, the efficacy of this. And thirdly, whether we should do it as a routine or as a salvage procedure. So in summary, POEM achieves significantly better relief of symptoms as compared to pneumatic dilatation. And the POEM resulted in a significantly higher rate of GERD as compared to left handle myotomy with fundoplication. So further research should focus on prevention and management of GERD after POEM procedure. Thank you very much.
Thank you very much, Professor Philip. Please stay on later on for the question and answer portion. Next, we have the pleasure of having Dr. Silvana Peretta, the Chief of Foregut Surgery and Advanced Intestinal Endoscopy Division of the Nouvelle Hospital Civil in Strasbourg, France. She is also the Director of the Esophageal Motility Laboratory in the same hospital, and the Director of Image Guided Surgery Institute of the IHU, the Director of Business Engineering and Surgical Technologies Innovations Program, and the Director of the IHU Surgical Endoscopy Fellowship. Without further ado, we have Professor Silvana Peretta.
Yes, good morning, everybody. I hope that you can, yes, I guess you can see me. It's a pleasure to be there with you, even if only virtually. I have to say that the previous speaker made my job very easy because they said pretty much everything there is to say on achalasia, how to diagnose it, how to select patients, and how to treat it either laparoscopically or endoscopically. I have to say I am in a good position because I'm a surgeon and an endoscopist and I run the physiology lab. So I think that this is possible, the best combination if you're dealing with a functional disease such as achalasia, because you can really offer patients all the different options and portfolio of treatment, selecting the right indication for the right patient. So with no further ado, I have nothing to disclose. I've always been a big fan of the endoscopic treatment of achalasia, and as also Philip just talked before me. Since the very first description of J. Pashrika back in 2007, almost more than 10 years ago now, and a very, I would say, bold first operation performed by the father of POEM and father of ESD, Dr. Haruhiro Inoue in 2008. Really, POEM made history, and it wasn't a very easy history to make, because let's not forget that at the beginning, when we were talking about poking intentionally a hole into the esophagus, the whole surgical community really had a riot, because they thought we were totally crazy. Who would intentionally dissect out the esophagus? We were all afraid of complications such as mediastinitis. You can be an endoscopist or a surgeon, you know that there is 50% chance of having a major complication and mortality. And as my very dear friend and colleague I have the pleasure to work with now, Dr. Lee Swanstrom said, God put the esophagus into the chest to protect him from surgeons, and that says a lot of things. But POEM did made history, and today we have more than 400 papers and publication and very solid literature to stress the fact that it's a good procedure and even more so a safe procedure. So if we look at the number of centers that were performing POEM back in 2010 and the number of centers that are performing POEM, number of cases that are performed today, there is a striking difference. POEM really made his way through becoming almost a gold standard for achalasia. As stressed by one of the previous speakers, I loved the lecture on the physiology and preoperative workup are very, very important, no matter if the patient is having a hilar myotomy or a POEM procedure. This is what everybody should understand, and you have to be comfortable and familiar with esophageal physiology and also endoscopy and, of course, the radiological imaging. This is the standard workup that we do in our patients. We start with endoscopy, we do a barium swallow, and we always, of course, do manometry. And very often we also do pH monitoring, especially if the patient is already complaining of symptoms of gastroesophageal reflux or if the patient had previous dilation or previous therapy. The POEM technique is very well standardized today. It consists in a few steps. First of all, identifying the right spot on the esophageal ward in order to perform the submucosal lift, the performance of the submucosal tunnel all the way down onto the proximal part of the stomach, on the cardia, and then the myotomy that usually is performed in a proximal to distal fashion, and finally the closure of the entry point with the application of endoscopic clips. Why POEM was successful and it made it through the years and penetrated the market easily is also because it didn't really require any particular different materials to be performed. You can use very standard ESD material. The one thing that I would not compromise on, and it's vital, is having CO2 insufflation. This is a procedure you cannot do if you don't have CO2 insufflation. You can use different kinds of needle, different kinds of knife. I think that everybody has the one that they are more comfortable with. I personally like to use the TT knife. I learned from both Inoue and Dr. Swanstrom. We are very comfortable with this, so I stick to it. It works very well in my hands, but really you can use any kind of dissection tool that you're more familiar with or that you do use for your ESD. Also, settings are very important when you're doing this procedure. I like to use personally spray coagulation and always have at hand soft coagulation in case I run into a major vessel. How does it look like? Well, our patients are all intubated under general anesthesia. I like to perform the procedure with the patient on the back lying supine, CO2 insufflation, high definition standard, single channel gastroscope. And as you can see here, we spend a lot of time in cleaning up the esophagus. The esophagus is your incision point. It's like your abdomen when you're doing laparoscopic surgery. It has to be squeaky clean. And I will show you some tips and tricks on how to achieve this kind of very nice, clean endoscopic field. Orientation can be tricky in the tunnel. So what I like to do is really address my endpoint of the myotomy, injecting a concentrated solution with saline and methylene blue in order to, or indigo carmine, in order to mark my landing point of the myotomy so that I don't lose orientation in my tunnel. You can add a few drops of epinephrine. I like to do that because I like to see while I'm dissecting the discoloration and the blanching of the mucosa. This is not something I use in order to stop bleeding, and it's something that you don't want to do. So be very, very, I would say, delicate and reasonable in the amount of epinephrine that you put in your lifting solution, because otherwise you risk to have a misunderstanding of your hemostatic control while you're doing the procedures, and then having a postoperative bleedings. Once you have identified your entry point in the mucosa, which for me is the anterior wall of anterolateral wall of the esophagus between 12 and 3 o'clock, you will enter and you will perform your tunnel using CO2 insufflation, as shown by the previous speaker, all the way down onto the lesser curve. I like to be on the anterior lateral right wall of the esophagus, again, in order to spare the sling fibers, and because for me is the safest place to go, and is also something that is going to grant you a lower rate of postoperative gastroesophageal reflux disease. You see here the myotomy being performed. I perform a selective circular myotomy, and I like to use a cutting in order to cut the muscle. A real limit for this particular part of the procedure, step of the procedure, the use of coagulation, which is much less precise. The last part of the procedure is clipping. We like to start the clipping just below the distal part of the mucosal entry in order to create an edge, and that will make the closure easier. You can use any kind of clips. One word of caution, try to use clips that are a little bit smaller, because if they have an end that is too bulky, it can create ulceration in the contralateral wall of the esophagus, and pain or uncomfortable, make the patient discomfort for the patient. You can also see a little bit of blanching of the mucosa. That was what I was talking about with the use of epinephrine. Once you have clipped, or even before you clipped, always control and check that the mucosa of the esophagus is intact. You want to rule out any burns that you may have made unintentionally to the esophageal mucosa, and any, of course, perforation. And this it does include also an inspection in retroflexion of the cardia. We always use in these patients endoflip to monitor our results, and we always use endoflip also to assess the length of the myotomy that needs to be performed. I was talking about how to make sure that your patient has a clean esophagus. This seems like a little detail, but for those of us who perform POEM or endoscopy in achalasia patient, you know that you can spend 30 minutes cleaning up the esophagus. Sometimes our POEM procedure takes 30 minutes, and we spend just the exact same time in trying to clear all the food remnants from the esophagus. So what do? We ask the patient to be on a clear liquid diet for the 48 hours before the procedure. And once we see that the esophagus is not clean, we place the overtube and we suction. We suction with an NG tube through the overtube, and we suction with the scope. And you can use Coca-Cola if you really have an esophagus that is really dirty and you cannot get rid of all the debris. Coca-Cola will do it. And actually, it's something that is recognized by the Endoscopic Society in the removal of intragastric balloons. So it is something that is safe to use. And anyway, you drink it, so you're not doing anything that you wouldn't do in your normal life. Of course, if you use it, let it stay for a couple of minutes, and then you have to wash out with saline before going in. Another lesson that we've learned, more and more we use a biliary extraction balloon once we have done our initial incision in the mucosa in order to facilitate and ease the penetration of the scope into the submucosal space. And we use this balloon also to inject the lifting solution while we are performing our tunnel, because it will make your field very dry. It's going to prevent the fluid from washing back on the scope. And it's going to really push it forward proximally, and it really eases and speeds up the dissection. Be careful with this balloon because the tip can be pretty rigid, and you have to control it properly. Otherwise, you can perforate either in the mediastinum, which is not a big deal because anyway you're going to do the myotomy. But if you perforate the mucosa, then it's a little bit more tricky. Especially if the case is tough, if it's a redo, or you see that the mucosa it's very thick, I would recommend to ask the anesthesiologist to do a steroid bolus right at induction together with antibiotics, which we always use, so that you will prevent the edema at the level of the incision. If you have a very, very edematous entry point, you're going to have a really hard time in closing it up. So do use steroids. A single shot is not going to do any harm to the patient. Actually, it's going to help the inflammation and is very, very useful. What if, and it happens to everybody, you have a very long enterotomy, mucosotomy in the esophagus, and you can't manage to close it with clips, either because it's irregular or it's too inflated. Well, if you do have a suturing device such as the overstitch device, you can use that in order to close your enterotomy. Do remember to use resorbable suture and not non-resorbable sutures, because they will create ulceration in the esophagus. It's a little expensive, but certainly something that will give you the opportunity to will save you from a tough closure. I do always monitor the abdomen of my patients. Once again, even if you're using CO2, you have to talk to the anesthesiologist. You have to have the abdomen at your reach so that you know that you're not over-insufflating. Unfortunately, today, we're not capable of monitoring and regulating, as we do in laparoscopy, the amount of CO2 that we were pushing into the patient. So that's something that can reduce make the job of the anesthesiologist much easier. And also it will allow you to monitor how much insufflation you have in the stomach. And that's very important, because especially when you're reaching with your tunnel or with your myotomy, the cardia and the lower esophageal sphincter, you really want to decrease the intragastric pressure so that you have a better reach and you're lowering the risk of perforation at this level. What do you do if you have a pneumoperitoneum, which is totally normal since you're insufflating a lot for a long time and CO2 is very volatile? Well, you just stick a needle as you would do in laparoscopy at the level of the umbilicus, or you could do it in the upper left quadrant at the Palmer's point, and you will just evacuate the pneumoperitoneum. Do so. This is something endoscopists do all the time if they have very long procedure. Why? Because it decreases the patient discomfort after the procedures and really improves their respiratory vitals. One thing that you have to be careful is there are some particular patients who actually have a very fragile gastric mucosa. And even with a little bit of insufflation, they can tear the gastric mucosa. It's something that I personally have seen 3 or 4 times. It can happen. So go and check the stomach from time to time. Once again, this is going to ease the last part of the myotomy, and is also going to give you a little more safety in terms of gastric insufflation. If you do have a fragile stomach, you can just slide next to the scope a very thin feeding tube that is going to evacuate constantly the CO2. And again, this is also helping the management from the anesthesia point of view. Where should you do your myotomy? I'm a big believer in an anterior myotomy or in anterolateral myotomy. Why is that? Well, because I can't help to think about anatomy being a surgeon, and there is a big tube that is just lying behind the esophagus, which is the aorta, probably 3 millimeters away from the posterior wall of the esophagus, and I don't want to run into any risk. And I also think that if you stick to the lateral, right lateral position, you're going to land onto the lesser curve, and from a functional point of view and a GERD point of view, it's better for the patient. I like to do a selective myotomy, because knowing the history of achalasia, we know that there is really where the disease is sitting, and it obliges you to be much more precise. Of course, it takes more time. It's just easy to cut everything through, but I think this is the way to go. And there is growing evidence in the literature that a full thickness myodily might be associated with a higher rate of gastroesophageal reflux disease. The length. This is the eternal question. I think that since 1913, when Heller described the Heller myotomy, he had no idea on how long it should have been, and we still have no idea on how long it should have been. It doesn't matter if it's laparoscopically or endoscopically. I tried to find an answer for laparoscopy. It was part of my PhD thesis many years ago, and there wasn't any. I think today you really have to rely on physiology and on imaging. You can assess the type of achalasia right before you're performing your procedure, your myotomy. It doesn't matter if laparoscopically or endoscopically. You can use also US to assess the thicken zone of the muscle that you need to cut, but mainly you have to rely on more reliable intraoperative monitoring, because we were doing functional surgery, and it is very important to balance the relief of the obstruction to flow with the incidence of GERD. And this is done through the EndoFlip. EndoFlip, it's a beautiful tool. We are lucky enough to be the center where it was used for the first time intraoperatively many years ago for laparoscopic Heller and Nissen funduplication. Now we use every time we do a POEM procedure. It tells us a lot. It helps us really tailor the length of the myotomy to the obstruction to relief, and that is probably the reason why we have a very low rate of gastroesophageal reflux disease after POEM. It tells you about the how well you relieved the obstruction to flow, and it's so intuitive and easy to interpret. You don't have to be a physiologist to be capable of understanding this preoperative and postoperative images. You can also rely on more sophisticated technology. This is something that we also did, and I know that Philip Hsu also use this in his center. You can rely on confocal endoscopic endomicroscopy in order to assess the myenteric plexus. This is something that is a little bit more complex, but if you really want to do something that is tailored and precise to the patient, probably we should more and more look into this different kinds of technology. Complications. Well, nobody likes to talk about complication, and this is a medley that both myself and Dr. Swanstrom put together for you to see. The first one, which is the most stupid one but can happen if you don't fix your cap properly, is to lose the cap in the tunnel. How do you get rid of it? Well, I just slide a biliary dilation balloon into the cap and pull it, because if you try to pull it out with all sorts of device, probably you're going to end up making a bleed into the tunnel and not getting rid of it. So just slide a biliary extraction balloon inside, you inflate it, and you take it out in the axis, and it's very easy, and then it really becomes a piece of cake. And then it comes out. Now, bleeding, it's something that you will need to deal with. For us, surgeon, bleeding is not as scary because we have, when we operate, a much bigger bleeding, but bleeding in a closed space as the tunnel can be difficult to treat. Prevention is essential. So if you see the vessel that is the same size of your dissecting tool, you can gently paint it and soft coagulate it. If you see something that is larger, do we use a coagulation graft Jasper with soft coag to take care of it. You can use a little bit of epinephrine and compression in order to clear up your field while the nurse is preparing you the right tool. Careful when you're coagulating onto the mucosal side, because you can create a secondary burn that can turn into a perforation. Big vessels are can be encountered when you're approaching here, as shown here, the gastroesophageal junction. Make sure that whatever you do it under vision, because otherwise you can run into this kind of problem. And what do? Compress. If you really have a problem stopping the bleeding, what you can do is get out of the tunnel and really heavily compress with your scope and with the cap from the esophageal lumen, and then you can go back and coagulate onto the vessel. Just to wrap up some postoperative management information. We always do an upper GI swallow on postoperative day 1, and then the patient starts a soft or liquid diet for 1 week. Why is that? In order to prevent the clip from dislodging and migrating, and then he can eat or she can eat whatever they want. We don't do POEM in outpatient procedures. We like to keep them 24 hours, but they go home right after they had their first meal. We use PPI for a period of 4 to 6 weeks, and we do an endoscopy 6 months after the procedure to check for esophagitis and take a very good look at the esophagus. So we did say before, the previous speaker said it, we have more than 7,000 cases of POEM worldwide, and POEM has been used also for other diseases besides achalasia. There is a total of 25% of all achalasia patients that are treated today with the POEM procedures, and patients simply prefer it. I have a really hard time proposing a hilar myotomy to my patients today, and I think I've done 1 in 8 years now. So it's not a procedure that we do very, very often. The results are good. I'm not going to spend much time on this because the previous speakers already addressed the results. I just want to highlight the fact that this is a procedure that seems to stand very well the test of time. There are some advanced indication. I would discourage you from starting from this kind of cases. Patients who have a sigmoid esophagus, very dilated esophagus, a failed open hilar, a failed laparoscopic hilar, a failed POEM. It is possible, but leave that when you're more experienced. Pediatric case can be a little bit more challenging, and when you have panesophageal spastic disorders or type 3 achalasia, you're going to need to perform longer myotomy. So maybe leave those patients for when you are more experienced. And I don't know why you cannot see my slides anymore. Let me see if I can get them back.
C'est un écran noir.
Ouais.
C'est la suivante. C'est une vidéo.
Okay, so I'm just going to show to end my presentation this video to show you that POEM can be used also to salvage other kind of diseases like this one. This is a patient who had a hilar myotomy for a epiphrenic diverticulum. He came back with dysphagia. And we decided to perform a salvage POEM procedure. You can see here that he had 2 problems: the recurrence of the diverticulum and the recurrence of the obstruction to flow at the level of the gastroesophageal junction. So the myotomy was done badly, laparoscopically, and it didn't relieve the underlying motility disorder and didn't relieve the obstruction to flow. We used the endoflip both at the gastroesophageal junction and at the level of the diverticular neck. And this is something that can be extremely tricky laparoscopically because you will run into the area that was previously dissected out, and it can be a little bit of a challenge. This is a patient who also had very prominent vascularization of the submucosal of the esophagus. You can guess it from those images. So we are working contralaterally from the diverticular pouch. We are being very careful with the control of the vessels in the tunnel. We have a very nice tunnel. You can see very clearly here the diverticular septum. So what we're going to do here, we're going to do the myotomy first, and then we're going to tackle the septum and cut it through completely. You see the TT knife in use with spray coagulation. We're going to run it all the way down onto the gastric cardia and junction. And now we're going to perform a complete septotomy using the same device. And you can see here that we're meeting with the normal esophageal wall, and then the mucosotomy is going to be closed with clips. Relative contraindication, I still do, if needed, or still recommend patients to have a Heller myotomy if they're not, or a Botox injection or dilation if they're not candidate for general anesthesia. If there is an associated hiatal hernia, I would do a standard hiatal hernia repair, Heller myotomy, and partial fundoplication. And if the patient has already a very high risk for GERD or has GERD, I will perform a laparoscopic procedure. Training is fundamental. It's a complex procedure to learn if you do not have ESD skills. If you have ESD skills, you really need to have a good understanding of the disease, which is a combination, of course, of profound knowledge, surgical skills and thinking, and advanced endoscopic skill. And with this, I'd like to thank you very much.
Thank you very much, Professor Peretta. That's very informative. Again, thank you for your time and sharing your expertise. At this point, I would like to acknowledge the other panelists, namely, we have Dr. Carlos Ejercito Jr. We also have Dr. Don Edward Estroselio. We have Dr. Emmanuel Estudillo, Dr. Roy Berberabe, and Dr. Arlene Cañones. So now we open the question and answer portion of our conference. First, we have some questions from the chat box. I think this is from the myotomy, Heller myotomy portion. The question is a fundoplication mandatory? Would anyone care to answer?
Yeah, so can you hear me?
Yes.
Yeah, so I think this was a very important question, and sometime way back in 1998, there was a paper which looked into with and without fundoplication, and they found like without fundoplication, it was 60%, if my memory serves me, and with the fundoplication, it dropped down to 10%. So a cardiomyotomy without a fundoplication in a surgeon's hand seems to be almost obsolete. It would be non-existent. There would be at least a partial fundoplication added by the large majority, if not all, of surgeons.
Thank you, Professor Sarfaraz. How about for POEM? Is fundoplication necessary when you do the endoscopic procedure? Professor Chu? Or yes, yes. Sorry.
Savannah, you can discuss first. Yes.
Yes, I think we think similarly, Philip. So you tell me if we agree or not right after I gave my answer. I think it's not necessary to start with. I think that's something that you can add on if the patient is not relieved by PPI. The first line would be PPI treatment. Once the reflux has been assessed both by endoscopy, manometry, and pH studies. And then if the system persists, you can definitely add a laparoscopic partial fundoplication. It would be a step-to-step procedure to me. We saw that probably 50% of patients out of the whole patient that we treat do complain of a persisting gastroesophageal reflux disease.
So, so for me to add, so for the past 300 cases that we have for POEM, we have one patient that require a laparoscopic fundoplication because of very severe symptom. And the second patient, we actually put in an endo-steam, so a stimulator to the LES. And for all the other patients, we have 20% reflux rate and most patients can be managed by PPI. So I think it's, as I mentioned in the lecture, if we want to treat reflux after POEM, I think prevention is important. And the recognition of anatomy to avoid cutting the sling collar fiber is one of the important points during the POEM. So if we avoid cutting the sling collar fiber, then we have already reduced this to just like less than 20 or even 15%. Then for those who require a fundoplication, then we can choose either to do laparoscopic or to do a endoscopic fundoplication.
Okay, thank you very much. I hope that answers the question. Our next question is, what would be your minimum preoperative diagnostic requirements before deciding for definitive operative procedure? So, Professor Philip?
So I think for me, preoperatively, I would definitely need endoscopy. Endoscopy is to check for any presence of pseudoachalasia. It is extremely important that we check the gastric cardia and there's no tumor and confirm. Because recently, I don't know why, but recently I have encountered 3 patients with pseudoachalasia. And that was actually missed because of the missing of the diagnosis of the gastric cardiac tumor. And they tend to be really small focus, but infiltrative at the gastric cardia. All the manometric finding is similar to achalasia, except that there's a presence of, sometimes presence of the esophageal motility. So not a peristaltic. So that is one of the important features. So, and the second thing is high resolution manometry nowadays, because we can then confirm the diagnosis and also to classify them into type 1, 2, and 3 and be selective in terms of the treatment. So, of course, we can also do a barium swallow, and that will give you also a good data. But to me, it may not be so necessary unless you think you suspect there's a sigmoidal dilatation or even end-stage achalasia. Then you can actually look into the configuration of the esophagus. So to avoid, even for end-stage or sigmoidal dilatation, you can still do POEM, but there will be much difficulty. So it would let you have a preoperative preparation of your approach to POEM in those cases.
Okay, thank you, Professor Philip. Dr. Roselio raised his hand. I think Dr. Roselio would want to make some comments about this.
Yeah. Can you hear me?
Yes, sir.
Well, I would like to thank all the speakers. Hi, Philip. Good to see you again. Thank you for the speakers for all the lectures and all the information that's given today. I would like to address this question to anyone who would, answer it, any of the speakers. We know that majority of the patients that we see with achalasia are clear-cut achalasia. However, in some patients, some of the patients with achalasia would have a borderline sigmoid esophagus. Do you have any clear-cut guideline on when to perform esophagectomy rather than a POEM? Or because we know that recently we've stretched the indication for the myotomy, and even with borderline sigmoid esophagus, we've been performing esophagomyotomy. And what is the clear-cut guideline on when to do an esophagectomy for sigmoid esophagus? Thank you.
Okay, so would anyone care to answer?
Okay, if there are no takers, I'll take it. Right. So I think, thank you. That is a lovely question. The question actually has a context, and therefore the answer has to be contextual. Usually when you see a dilated esophagus, these are not patients who come for the first time to a doctor. They have been managed over a period of years with either a medical colleague or a surgical colleague or our own centers. So these are not patients who come out of the blue. They have a history of having multiple therapies. It could be pharmacological, it could be pneumatic dilatation, It could be a poem in the past. It could be Hellas in the past. And when you see, let's say, the rare example of a very dilated tortuous sigmoid esophagus upfront, I think that's a patient which probably is too neglected and something which you would not see so commonly nowadays. And that would be a difficult conundrum. But some patient who, most of the patients would have had a history of some sort of a treatment. Now, there has been an advocacy for esophagectomy for these kind of cases. And if you've seen their success rate has been pretty good. The quality of life has improved with esophagectomy. They have described in the paper that there's 10% leak rate. And this comes from a multi-center report. Having said that, our center, we tend to go more conservative, and patients do not agree for an esophagectomy so upfront. They're not very keen with esophagectomy or gastric pull-throughs. They're happier taking a pneumatic dilatation. They're happier taking a poem. They're happier taking a redo balloon dilatation as well as a redo poem instead, rather than going for a esophagectomy. So the treatment is largely conservative in our center. We realize that esophagectomy is increasingly being an option. But if you're asking what is the exact diameter of the esophagus, what is the kind of tortuosity that you're going to see objectively, I'm afraid I am not aware of any guideline in that direction. I'll ask Dr. Peretta and Dr. Philip to munch into this and tell me if there are any guidelines, but I do not see them as far as my memory serves me.
Yeah, I totally agree with you. That was an excellent answer. There are no guidelines as far as I know too. And I think you pointed out something that needs to be very clear when you're approaching this kind of patient, which is quality of life. We're doing functional surgery, and esophagectomy is something that really is the last resort when your quality of life is so deteriorated and nothing else has worked, including poem dilation or even surgery. And only then you can discuss with the patient whether he or she feels comfortable with undergoing esophagectomy. I think that's the main point, really assessing the quality of life, and it's a patient's choice. It's not a surgeon's or an endoscopist's choice.
Yes, we have three patients who have end-stage achalasia. They require esophagectomy. We do it by minimal invasive approach, and those are really having, symptomatically, they can't eat and always have a lot of food inside the esophagus. And so for those cases and the really, really dilated esophagus, we actually treat them by esophagectomy. But this is a really small group of patients who have a very poor quality of life, and even after endoscopic treatment. So we try poem for them and they fail. So that's why we do esophagectomy.
Okay, thank you so much for your answers. Actually, in the earlier part of my practice, if I see like an 8 cm or even 10 cm esophagus, sigmoid esophagus, I was quite aggressive with doing esophagectomies until I encountered a severe morbidity, which ended up with a mortality. And since then, I would always try to ask the patients, if what they're considering, what their symptoms are, and I'd always tell them, let me try with a Heller's esophagocardiomyotomy with a door fundoplication. If it doesn't work, then maybe we can, if the symptoms are still persistent, maybe we can consider something else, dilatation or even esophagectomy. But since then, I've always did a myotomy. Thank you.
Thank you very much. We have a question from Dr. Arlene Cañones.
Good afternoon, everyone. Thank you for the very nice lectures. I just want to ask Professor Peretta and Professor Chu regarding jackhammer esophagus. What's your experience on doing poem? Because as far as when I was training under Dr. Inoue, I remember having patients with the jackhammer esophagus, and he is doing a very long myotomy for that. But it's also part of one of our studies there. So instead of doing a long myotomy, you do myotomy on other parts of the esophagus. So I'd like to hear your experience on that. Thank you.
So yeah, so I think I can discuss a little bit, and then maybe Savannah can also discuss about jackhammer. So I have limited experience in doing poem for jackhammer. I have probably only 1 or 2 cases, but I think it's important for us to correlate the myotomy length as compared to the HRM finding, because you have to cover the tight muscle fiber constriction area so that we can relieve the symptom. And of course, nowadays we cannot just be a standard. So at the very beginning of development of poem, we have a standard myotomy. For example, any patient we do lead 10 centimeter. But nowadays we can be selective. So for type 3, of course, we also need a very long myotomy. But for type 1, or most of the time, a short myotomy will be able to manage and achieve the similar purpose as compared to a long myotomy. So, but we are waiting, of course, for the randomized trial or any other research. But jackhammer, we need a longer myotomy to cover the spastic area. It can be treated by poem, of course.
Thank you,
yes,
Professor Chu.
I agree with Philip. Those are patients that we don't want to have. Those are the patients that nobody wants to treat because the results are, in any case, very tricky and not always as good as we wished. So I only treated 2 patients, and it's important to discuss with them that whereas we are very comfortable with standard achalasia and relieving dysphagia, these patients often have chest pain, and these are symptoms that no matter what you do will not disappear 100%. So I think that you really have to discuss realistic expectation. In terms of the procedure, if I had to choose between surgery and poem, I would do definitely poem because I can tailor better based on HRM the length of my myotomy and make it longer proximally. But again, I don't think that we have the right solution for this particular category of patients yet.
Thank you.
Okay. Are there any further questions?
Well, if there are none, then I'd like to ask Dr. Philip and Dr. Peretta, because it's an honor to have them on board. And as a surgeon, I always had these questions, and this question comes as a very basic question. So forgive me if I make a fool of myself here, but I would still like to know what is it about the length of cardiomyotomy in patients who have normal LES tone or normal IRP, and also when in cases like type 3 where we have a spastic component, what is it, philosophically speaking, conceptually speaking, or physiologically speaking, what is it that we are doing with the length of cardiomyotomy which is working in these cases and not working with a shorter cardiomyotomy? What is the concept behind this?
I can, that is the reason why I like to use endoflip intraoperatively, because it can give you different information from manometry. And when I don't have it available, it happened a couple of times because the machine just froze, I'm very uncomfortable. It's like driving with your eyes wide shut. I think that a very interesting study that we've done years ago with manometry and endoflip, we measured what was the length and the location of the myotomy that would really give you the maximum relief of the obstruction to flow. And we really could see that is a very limited area really around the cardia and around the LES, which by the way is asymmetrical, and that's why I like endoflip, because you can see 360 degree. No matter how long we would prolong the myotomy proximally, it wouldn't change anything in the terms of pressure and in terms of distensibility and resistance to flow. So I think that we need tools to guide us, especially in those patients, in order not to disrupt, but really tailor and do some and add more precision to our intervention.
Thank you very much. That's an excellent answer. Dr. Philip would like to say
Yeah,
something.
I fully concur with Savannah. And also, I think in the past, as you also mentioned about the category of hypertensive lower esophageal sphincter. So this is kind of difficult case to select because sometimes their symptom wax and wane, and but they are sometimes having very severe symptom. And but then after we do the POEM procedure, they end up in very severe reflux, and that may, the current also the category of EGJ outflow obstruction. So I think it is challenging for us to select whether we should actually cut into the sphincter to relieve the symptom. And I think this kind of patient required more investigation. And perhaps endofib is one of the excellent investigations and that can guide us in terms of the treatment and the length of the myotomy. I fully agree.
Thank you. Thank you, Dr. Philip.
Okay, thank you very much. Are there any other questions?
Sir, I have one more question.
Go ahead.
So for post-POEM procedures, and if these patients have symptoms of GERD after POEM, how do you select the patients to do ARMS or endoscopic management for the GERD or do a fundoplication?
Okay, so for me, I have discuss and think about the anti-reflux mucosectomy ARMS for treatment of GERD after POEM, and I selected not to do. One of the reasons is because ARMS induce stricture formation at the G junction, and this is not a very controlled manner of stricture formation. So if we have a overwhelmed stricture that causes dysphagia, it would actually cause difficulty in managing those patients, especially remember the achalasia patient have aperistosis persists even after myotomy. So I personally prefer not to treat it by ARMS. And I think POEM-F is upcoming and probably one of the treatment option. And I think there are expertise doing a transoral fundoplication as well with the TIF device. So I think they are still under investigation. As I mentioned, most of the patient can be just managed by low dose of PPI, but there will be concern about the long-term effect of PPI. So I think eventually we need to find a way that we can manage. Converting back to a laparoscopic fundoplication is a way, but that defeats a purpose of doing POEM at the very beginning. And the expert will argue, why don't you just do a laparoscopic halomotomy and the fundoplication at the very beginning? So I think this will be the next 10-year or 5-year argument, and we need more evidence.
I just have something to quickly add. I think that if a patient comes back to me complaining of symptoms of reflux, the very first thing I would do is study the patients completely again. So I would really want to make sure that it's really gastroesophageal reflux. This is not fermentation and stasis, and it's not residual obstruction on the level of the LES. So for me, I start again all the workup in order to understand what I'm dealing with, and then I will decide what to do. I do have experience with TIF. I think that is something that you can, or any other endoscopic treatment that you can propose to the patient if they have mild reflux. If they have very severe regurgitation, I think that an old-fashioned fundoplication performed laparoscopically is going to do the patient very well. It's a very good procedure, standardized, and I don't think that if we do that as a step-by-step approach, and which will only probably be necessary in 5% of all the POEM patients, it's something that I would say, debatable. It's a different way of treating the disease, which is also minimal invasive. So.
Yeah, I think I would like to add something here, if you allow, Dr. Joel. Yeah, so basically, an achalasia is an esophageal reflux problem. And the patient essentially does not differentiate between an esophageal reflux or a gastroesophageal reflux. And converting a patient from an esophageal reflux to a gastroesophageal reflux is some sort of a defeat in my mind at the very beginning of the problem. So a bigger picture is that we need to, from endoscopic point of view, we need to do POEM plus something to get these things better. I'm a big fan of POEM because my medical colleague does it and he bails us out all the time from so much difficult situation. Having said that, I think we still have this feeling that Heller with fundoplication is still serving the purpose of a large number of patients in our subcontinent, where prolonged PPI is an issue, doing an HRM is an issue. And since we're talking in Philippines, I think my Indian problem is probably also a Philippine problem. Economics is a problem. I do see that we need to develop endoscopy more in the future. I'm not saying, I'm not down, I'm not putting it down. I'm just saying that we need to develop this a little further to make it more widely available for all category of patients.
Yes, sir. I definitely agree. The Indian problem is also the Philippine problem, the economic factors for the patients. Maybe we can hear from Professor Sutep from Thailand.
Hi. Yeah, I do very much enjoying the talk and discussion. So I think same thing. We do have the same issue in Southeast Asia or South Asia, that one of our concern would be, the economic issue. But anyway, yeah, of course, I'm very much enjoying the conversation. Thank you.
Thank you very much, Professor Sutep. At this juncture, if there are no further questions, we can give a few minutes for our friends from Medtronic. We have Ma'am Joanna Marie Valioso and Patricia Reyes.
Hello, good afternoon. Can you hear me? Okay, let me share my screen. Okay, so good afternoon, everyone. On behalf of Medtronic, first of all, I would like to thank you for you healthcare frontliners for your dedication, and most especially this COVID-19 pandemic. So, okay. So I am Joanna Valioso from Medtronic. I am handling the visualization portfolio. And just in case you will be needing these products, so I am handling the following. What you see in your screen right now is our Elevision HD1 system comprising of the following. We have our native full HD camera system, 26-inch monitor, 50-liter insufflator, our LED light source, laparoscopic suction irrigation pump, and also we have the recorder. Aside from that, we also have our WEM SS501SX and Argon 4. So what's special about this electrosurgical unit is that it has the endoscopic cut function, and this mode is developed specifically for endoscopic procedures. It provides precise control of the incision and allows resection with control and quality. So if ever you have queries, concerns, or inquiries regarding these products, you can reach me at the mobile number and email address located at the bottom right of your screen. That's all. Thank you.
Hi, good afternoon, everyone. Can you see my screen? Okay. Good afternoon. I'm Patricia Reyes from Medtronic. It is my pleasure to introduce the members of the entire surgical team in charge of the individual institutions of Quirino Memorial Medical Center, Rizal Medical Center, and Batangas Medical Center. So for energy devices, your Valley Lab machines, ligature and sonicision, we have Bell for Batangas Medical Center and JC for Rizal Medical Center. For sutures and hernia solutions, we have Ching for Batangas Medical Center, and yours truly for trocar, lab instrumentation, open and endoscopic stapling devices for Quirino Memorial Medical Center and Rizal Medical Center. Should you have any questions or concerns, please do not hesitate to get in touch with the representatives in charge of your institution. Thank you. Back to you, Dr. Selaje.
Hello.
Thank you very much.
Anyway, hello, this is Alan. I would like to take this opportunity to thank, of course, Professor Silvana Pereta, Professor Philip Chu, and Professor Sarfaras Baig for giving their time to us. We're really indebted for giving their invaluable time and their expertise to this conference. Thank you so much for your time. Anyway, hello.
So we would like to present certificates of appreciation to our speakers for this afternoon. So it reads that this certificate of appreciation is awarded first to Dr. Philip Chu, to Dr. Sarfaraz Baig, and to Professor Silvana Pereta for their valuable support as speakers in the online UMIST conference entitled The Essentials of Achalasia, given this 11th day of June 2020. So this is signed by the different chairs of the three training institutions, namely the Quirino Memorial Medical Center, the Rizal Medical Center, and the Batangas Medical Center, as well as the training officers and the program director of the UMIST, and the president of PALES, Dr. Ernesto Tan. So thank you very much to our esteemed speakers.
For the participants, please don't forget to answer the form after this one. Arlene, can we see? Feedback form.
Arlene, remind the feedback form. Hello.
Okay,
The feedback will be, I think they will be rerouted to the link after they leave the Zoom.
It's important for the CPD units. PRC.
Yeah. So thank you very much. Thank you very much, everyone.
Thank you. Thank you, Phil. Thank you, Siwan. Thank you, Safak, and all the units.
Thank you so much.
Yeah, of
Thank
course.
you.
Thank you.
Thank you.
Thank you. Okay.
Thank
Take care,
you so
everyone.
much.
Thank you very much.
Thank you. Yep.
Thank you, brother.
Thank
Thank you,
you.
Dr. Joel.
Thank
Thank you, Philip.
Dr. Philip.
Thank you. Thank you very much. Thank
Thank
you.
you,
Thank you, bye.
Safras. Thank you. Thank you.
Thank you.
Bye, everyone.
Yeah. Bye. Bye-bye. Bye-bye.
Bye.
May nag-answer na sir sa feedback. May naka 21 na tayo so far.
Okay, thank you.
I'm counting.
Yung members ng UMIST, can we stay online? Kasi we would want to present can we ask Kevin, si Kevin magpe-present eh. Kevin will be presenting the Arlene,
Gawa na lang tayo.
Arlene, read.
Paano lang po na bago? Okay, sige po.
Arlene.
Send ko na lang sa
Off na lang.
thread.
Shutdown na tayo. Okay, tapos gawa na lang
Thank you
ulit.
po.
Off na lang natin, Arlene, and then
Okay po.
sign in na lang tayo ulit para
Okay
yung
po.
yung ano na lang natin.
Thank
Send
you.
mo doon sa group natin yung link.
Okay po.
Makapasok tayo ulit.
Okay po, sir.
Gusto kong